our opening remarks about the transplant program at NH with Dr. Sharat Damodar sir. He's a senior consultant and HOD of hematology. He's the clinical director at Mazumdar Shaw Medical Center, Narayan Health City in Bangalore. As the senior consultant and head of adult hematology and bone marrow transplant, Dr. Sharat Damodar is a distinguished medical professional with extensive expertise in the field. So please, sir, I would welcome you to give the opening remarks to start off this conclave.
Yeah, thank you, Aditi, and first of all, congrats to the entire team for organizing this. I think we've been planning this for some time, and you have to start somewhere, and this is a good start. I'm hoping that, we can get it onto a bigger scale very soon. So quickly to take about 5 minutes just to tell you of the story of how NH has actually progressed on transplant. So primarily being a cardiac center, you would expect that you should have started with a heart transplant, but then this is what happened in 2004. The first floor private ward got converted into a BMT unit. And then things started off as a bone marrow transplant there. And this is that child who's diagnosed with thalassemia and is now going to college. And the donor is old enough to get married very soon. So that's a good success story in a totally cardiac center where things got started. So clearly, with a will and a way, you can do these things. We all know the support which is required to do transplant, and clearly some of these systems kind of fell into place from that time. And clearly, we've got very good visionaries at NH, both Dr. Shetty and Dr. Kiran Mazumdar decided to take this forward, and thereby we've got this great infrastructure there in the health city, including the addition of the additional, medical center, which is the multi-specialty wing now, and the cardiac center, which is also existing. This is what the state-of-the-art BMT unit is, both for adult and pediatric, and the huge amount of nursing staff support which is required to run such a place. And then this further expanded now to a 24-bedded unit. So clearly we're getting better and better at doing transplants. And you can see the support systems going up, clearly telling you how much is required to get some of these things going. This is our story on the hematology side, on the transplant numbers over a period of time, over the last 20 years, starting with single-digit numbers and then going into the 200s in the last few years. So we're a big center in the country now for transplant. Some of the diseases, I won't go into details on this, primarily hematological diseases, cater to both adult and pediatric, and a larger pediatric unit because there's a lot of thalassemia load which we cater to. And we're a primary refer for the allogenic transplants. And in today's world, the newest thing is to do half-matched or haplo transplants, which is the next big thing in this. Now, clearly, once you've achieved all of this, clearly solid organ. And this is the area where which I think we've all now entered into, and clearly the whole idea of having this meeting was to highlight this work of NH in these areas, in these specific areas. And it's nice that we've got an entire day's program, and we've got specialists from all these areas who are going to give their little talks. This is also being telecast live on a link now, so there are people joining in to actually listen to that. Just to give you a flare of the numbers, so this is from the renal transplant section. We are nearing about 600 transplants till now. And we've also had a kidney pancreas transplant done, which is some time back, which is one of those rare things which happens. Liver transplant, this is the numbers here in the center here itself, but across the group, it's a much larger number. We've got a big team there, which is kind of involved in liver transplants, both adult and pediatric. This is the heart and lung transplant. So this is the numbers here. So clearly, this has become a big center now for referrals for all these, transplants, and the whole idea of trying to get people together. Because end of the day, there are a lot of common services which all of us use, right? From the blood bank, the lab support, the HLA, typing, cross-matching, and a lot of interdisciplinary support, which is also required to run some of these things. I'll end on my last slide to tell us that, it's not just transplants. We're now all getting into the field of immunotherapy. I think we've been talking about some of these things like CAR T cell, where you're using your own cells. And this was the first patient who got infused, and this is the most recent one where we had a little press meet the other day, who's crossed 1.5 years after having relapsed lymphoma, and he's walking, talking, and absolutely well. So these are success stories which is putting NH onto the immunotherapy map. And that's a nice way for all of us to kind of look forward to. And clearly, when we have multi-specialty involvement, clearly everybody grows in the bargain. So thank you for listening to this. And with that, I'd like the rest of the program to continue. And thank you for your hearing. Thank you.
Thank you so much, sir, for that kind introduction and overview of the transplant program at NH. So with that, we'll start off with the liver session. Our first speaker is Dr. Vinay Kumar, and he'll be talking about indications, pre-transplant care, and optimization of chronic liver disease patients. He's an associate consultant hepatologist at Narayana Health City. Thank you so much.
Good evening to one and all. Thank you for the organizers for making such an event. This is one of the unique event where multi-organ transplant is spoken about. So first of all, we start with the liver transplant as such, and I'll be talking about a part of liver transplant program where I'll try to explain about the indication, pre-transplant care and optimization. My fellow speaker will be speaking about the optimization and evaluation part of the this one, and subsequently we'll talk about the what is a pediatric liver transplant and its various aspects. And coming to the end, we'll talk about the outcomes. So talking about the indications, like first of all, I want to give a brief thing about liver transplant, why it is important, because overall, entire world, the liver problems are day by day increasing, especially with the pandemic of obesity. The liver involvement along with liver failure is progressively increasing, as we know. So liver transplant is becoming one of the important treatment when such patients end up in chronic liver disease and end-stage liver disease. What the benefits it offers is it offers excellent survival with improved care, prevention of long-term complications with which the patient had to suffer if he is not going through transplant. And also, overall, if you see, it has a better health-related quality of life. Now, in most cases, the risks associated with recurrent disease definitely outweigh the success of transplant. Now, if you see, liver transplant is also very successful in pediatric age group as well. And when compared to the previous outcomes, nowadays the outcome is almost reaching 90% survival at 1 year, and also a better survival rate at 5 years. If you go to the history, one of the first transplant was done by Thomas Tassel in the year 1963. Subsequently, the progression in the immunosuppression has taken our transplant program to newer heights. Now, if you just a brief slide on how does the liver disease occur. There is injury to the liver which causes liver damage. Subsequently, the immunological drive which leads to disruption in fibrosis, subsequently leading to cirrhosis. The cirrhosis gives you two paths: when either they end up in complications and death, or you transplant them so that the outcome is better. If you come to the indications, any patient who is having chronic liver disease has developed decompensation, better to evaluate for transplant because the success is much better, because decompensation reduces the survival. In a case of a compensated cirrhosis, the usual survival is about 80 to 90% up to 5 years. But as the decompensation starts, the survival drops to less than 20% in 5 years. And usually the death rate is almost more than 50% every year as the decompensation progresses. So the usual indications in pediatric age group, I think Dr. Sana will be speaking more about this. So chronic liver failure, cholestatic liver disease, inherited metabolic disorders, chronic hepatitis. In case of acute liver failure and metabolic liver disease, definitely we need to evaluate the child as early as at the earliest, so that the damage is not worse. In case of adults, we have 3 groups of patients. One, in case of acute liver injuries and failure. Second, chronic liver disease patient. When you come to acute liver failure, the indication is based upon the guidelines or criteria which are set by King's College. Usually, paracetamol toxicity is one of the important cause of acute liver failure, especially in the Western countries. In India, if you take the etiology wise, the more number of cases are, the etiology is not known.
In case of India, even the acute viral hepatitis causes are also increasing in number. Whenever we say the indication, usually the KCH criteria is used. KCH criteria has one major criteria where it says the prothrombin time more than 100 seconds or INR more than 6.5. They can, the survival without transplant is very poor, hence they need evaluation with transplant. Or if they are not satisfying the major criteria, they can, if they are satisfying 3 out of the 5 minor criteria, they can get listed for transplant. Or you can evaluate for a living donor liver transplant in Indian scenario, because if you see the overall cadaver program is not so robust in our country. Also, there are other indications where they present with acute failure conditions like acute Wilson's and Budd-Chiari. They also can be considered as one of the important listing criteria for transplant. If you see the next group of patients, that is chronic liver disease group. So the important causes in India is alcohol, obviously. The fast moving cause right now is non-alcoholic fatty liver disease because of the pandemic of obesity. And thankfully, the viral hepatitis causes are coming down, although they also still they are making the major chunk of people who require transplant as the disease progresses. Other important indications in adults are the metabolic diseases like Wilson's disease, hereditary hemochromatosis, and other congenital hepatic fibrosis and other defects which can also be presenting in the adult age group. The third group of patients which I was talking is other minor indications where they have other indications other than liver failure as such, when they have severe hepatopulmonary syndrome, or they have familial amyloid polyneuropathy, or case of polycystic liver disease, which is progressively worsening, or liver tumors. Liver tumor indication for surgery is when it satisfies UCSF criteria, or in some cases Milan's criteria, where the tumor number and the size matters. If it is beyond the criteria, it is very difficult to do the transplant because the success is little low. So whenever we do transplant, we always think of a number where the predicted 5-year survival at least should be more than 50%, so to ensure the maximum utility of the transplant program. And this improves the overall benefit and the outcome success in the end in those patients. Coming to the contraindications, few of the contraindications which we should always think is any patient who is not meeting the criteria, especially in the chronic liver disease patient, we often take the MELD score is around more than 15. They are better to be transplanted. But if they are, in an early stage, then we can wait and watch. Or if the patients are having acute alcoholic hepatitis, although now the thinking is that we can relax this indication, because nowadays we have seen even with the alcoholic hepatitis in ACLF like presentation, the outcome is excellent when compared to medical management alone. Many papers from across the world has shown that outcome is better, but the only problem is that the relapse rate is quite high in this group of patients. Although with successful counseling and with adequate involvement of the patient and the family, we can always have a better outcome even in this group of patients. Or if the patient has a history of going back to the alcoholic abuse or other substance abuse, also having contraindications to the liver transplant. And if you think that will not be able to adhere to the medical treatment as well as strict follow-up regimen, then it is a difficult case to handle. Then it becomes a contraindication, especially in a psychological condition or psychotic condition in the background. The other relative contraindications which we apply is if there is advanced age. Usually we take around more than 65 years, or if there is a source of infection which is actively involved, actively causing problem in these patients. And also with the patient with a poor nutrition always becomes a relative contraindication, because the success in those patients, especially when there is a severe sarcopenia or nutritional deficiency, is quite bad. So this was a part where indication and contraindication. My other colleague will be talking about the transplant evaluation in these group of patients. Now I'll try to talk about a brief overview of how to optimize this kind of patient. Although it's a very vast topic, I'll try to divide into 3 groups, where One is to attack the primary cause. When there is alcohol liver disease, we have to obviously, stop taking alcohol and also treat the causes. Second, when there is involvement of, there is a complication associated with chronic liver disease, and we treat them accordingly, like ascites management with a diuretic, or we can advise for tips for better management, variceal bleeding, which can be controlled with regular endoscopy and the drug management, and support the organ failures when it develops, especially requiring hospitalization, because these patients can progress to failure. So usually HE is controlled with regular regimens with lactulose and antibiotics, which have given a good response. Of course, there are many other drugs which can be used in the various pathogenesis of this complication, and it is showing better outcome in spite of delay in transplant. Also, the other conditions like requiring is the complications associated with hepatopulmonary syndrome, which needs to be evaluated and treated with better care. Although transplant is a better option to treat them rather than going for medical management. So these are the other complications which needs treatment overall. One is the hemodynamic abnormalities and AKI. They have certain criteria which, if they're fulfilling and they are into hepatorenal syndrome, then they need aggressive treatment with albumin and other vasoactive therapies, which can be helpful in tapering the crisis and managing those patients better. So with this, I'll stop my talk. The other thing about one last slide is about the common drugs which we use. We should always be careful about these drugs, NSAIDs, and narcotics and statin drugs. But careful evaluation and appropriate patient selection can be, can matter in this group of patients when we use this kind of medications. So overall, if you see the outcome with these, if there is
Any indication is better rather than doing a medical management alone. So at the end, if you think about transplant, rather than thinking it as a last resort, better to subject those patients at the earliest, so that they are not in a severe complication or severely malnourished, so that the success rate is quite high. So with this, I'll stop my talk. Thank you. Thanks a lot.
Thank you so much for that engaging discussion. Next, we have Dr. Vidyadhar Maitri. He's a consultant hepatologist, liver transplant and ICU consultant at Mazumdar Shaw Medical Center, and he will be talking on pre-transplant evaluation of end-stage liver disease patients. Also, just a reminder, we'll have question and answers for all the liver talks after this session is complete. Thank you.
Good evening, everyone. I'm going to talk about the preoperative evaluation and assessment of the liver transplant recipients, both adult and pediatric patients. This part has been covered by Dr. Vinay, so I'll just skip this part. What is liver transplantation? Liver transplant is the replacement of the diseased organ with some or all of the healthy liver. Most commonly used practiced liver transplantation often is orthotopic liver transplantation, and liver transplantation is a viable treatment option for the end-stage liver disease. There are different types of liver transplantation: orthotopic liver transplantation, living donor liver transplantation, split liver transplantation, and auxiliary liver transplantation. Now coming to the patient evaluation part. Patient evaluation includes a multidisciplinary team, which includes hepatologist, transplant surgeons, anesthetists, cardiologists, and intensivists, and healthcare workers and psychologists. Goals of the preoperative evaluations are evaluation of hepatic dysfunction, assessment of concomitant diseases, and optimization of the patient prior to the surgery, and patient motivation for the procedure, as well as family support. It also includes identify who, when, and how. Identify the patient selection, which includes indication and contraindication, which has been covered by Dr. Vinay. Then when, timing of the operation, which is most important. Doing the transplant either too early or delaying it for a longer duration, both carry the risk. So it is very important to take a time the transplant very correctly. Then last part is how prepare the patient and patient on waiting list on the waiting list. These are all the indications. I'll just skip through it. Timing. LT should be considered in patient with liver disease, and procedure would extend life expectancy beyond what natural history of underlying liver disease would predict, in whom LT is likely to improve quality of liver. These are all the supragen criteria, which Dr. Vinay has already covered, so just skip through it. Different prognostic scores which are used for evaluation of the patient are child CPT score system, MELD score, and MELD NA score. Child target scoring involves five entities: encephalopathy, ascites, bilirubin, albumin, and INR. Based on all these symptoms, patient will be graded according to child A and B and C. Child A from 0.5 to 0.6. Child B includes 7 to 9, and anything more than that is child C, which carries a higher risk. Pitfalls of CTP score are: one, it involves intra-order variations subject to nature of the encephalopathy and subject to nature of ascites assessment, healing effect of biomedical parameters, and that does not incorporate renal function. Now moving on to MELD score. MELD score was initially introduced in February 2002. It was originally developed for the validation and assessment of the short-term prognosis of patients with cirrhosis undergoing TIPS. This is a formula which is used for calculating the MELD score. It predicts usually estimated 3 months survival for a score of 6 is 90%, and MELD score more of 40 carries a survival rate of 7%. Patient with MELD score above 15 is accepted for the candidate for liver transplant. Patient with MELD score less than 15 or child B is listed for followed up until they become a child C or develop HCC or other MELD exclusion criteria. These are the few of the MELD exclusion criteria, which includes pure pH, HCC, hepatopulmonary syndrome, cystic fibrosis, primary hyperoxaluria, and other things. Patient with MELD score of more than 30 carries significant postoperative morbidity and mortality. Last one is MELD sodium score. Patient with a MELD sodium score of 11 to 12, 21 to 30, and more than 30. They have been categorized into three groups. Patient with more than 30 carries a twofold risk of postoperative morbidity and mortality. It increases to 4.7% and 7.6% as the score increases. At 3 months and 1 year, MELD NA score was superior to those of MELD score in predicting mortality. Two routinely followed liver transplant options are: one is living donor liver transplant, another one is deceased donor liver transplant. The advantage with living donor is it in systemic evaluation of the patient in the preoperative time can be done. Second is it is possible to medically ameliorate some of the abnormal functions of the organ. And last, more of a elective kind of situation. Whereas DDLT, most of the time it is emergency, and assessment is usually done at the time of listing. And whenever the patient comes, the assessment is not possible. It is an emergency procedure. These are all the list of tests which are required in any patient who is undergoing transplant. It includes laboratory parameters, cardiopulmonary assessment, cancer screening, infectious disease evaluation, psychotherapy, psychosocial evaluation, and other testings. In cardiac evaluation, it includes ECG, 2D echo, calcium scoring, and DSC. The different manifestations of the cardiac enrollment are prolonged QTC, hypertension, ischemic cardiac disease, cardiomyopathies, heart failure, hepatopulmonary syndrome, and portopulmonary syndromes. In cardiac coronary artery disease, Overall prevalence of coronary disease in CLD is it ranges from 2 to 28%, and recently it carries the highest percentage in NASH group of patients. In them, it increases up almost up to 23%. Risk factor for CAD are age more than 40 years, male gender, hypertension, diabetes, and obesity, and NASH. In cardiac evaluation, one is DSC. DSC is for the functional assessment of the heart. DSC is the most commonly used screening test that we have today. Sensitivity and sensitivity of DSC is 12 to 100% and 57% to 100%. Calcium scoring, if the calcium score is 0, there is no evidence of CAD. From 1 to 10, it's a minimal evidence of CAD. 11 to 100, mild evidence of CAD. 100 to 400, it carries a moderate evidence of CAD. Anything more than 400, it carries a very high risk for CAD. There are a few studies which have carried out study on calcium scoring. Assessment of functional capacity of a patient. It includes, it can be done using MAD score or KAP score or hand grip test. Metabolic MAD score is all, as you know, it includes scoring of 1 to 12. And usually anything MAD score of more than 4 is taken as acceptable. Anything less than MAD score of less than 4 needs a further cardiac evaluation. This is a Karnofsky score. In this score, we go from 100 to 0. 100 is almost like normal patient, and with each step it goes on decreasing. This is the last one, which is hand grip test. Usually, hand grip test is good assessment test of patient outcome also, because a patient with a good good skeletal muscle reserve also has a better outcome in organs. Next, moving on to pulmonary evaluation. Pulmonary evaluation involves multiple tests like chest X-ray, pulmonary pulse oximeter, ABG, and pulmonary function tests. The manifestation of pulmonary involvement is in the form of restrictive lung disease, hepatopulmonary syndrome, portopulmonary syndrome, pleural effusions, hepatic hydrothorax, and respiratory alkalosis. Next is renal involvement. The tests which are used are serum creatinine and urea creatinine clearance. Usually creatinine is a poor marker because in cirrhotic patients, both muscle mass is low because of multiple reasons. As a result, serum creatinine is not a very good indicator. So we have to either go for creatinine clearance, or if creatinine clearance is less than 40, then we have to go for a DTPA scan. And then last one is serum electrolytes. Next one is hematological evaluation. In this CBC coagulation profile, serum fibrinogen and FTP. Because in these most of the patients, serum fibrinogen is known to be low, and if it anything patient with less than 100 milligram per deciliter, 100 milligram per deciliter carries a poor postoperative prognosis. Then hepatic evaluation. Last one is that hepatic test. Last one is psychological evaluation. Because patient should be in a sound state of mind to give a consent for the transplant. This is the general physical examination of the patient to undergo for the transplant. Consultation includes cardiac, respiratory, psychiatric, gynecology, if in case of males, and anesthesia and transplant committee. In case of pediatric, apart from all these tests, the special consideration in pediatric patients are a patient with Alagille syndrome will also have a POPH. So a patient with anybody with Alagille syndrome should be looked for the POPH. And in case of pediatric, PEL score is used now instead of not MEL score. And then genetic studies are needed in case of pediatric patients. Thank you.
Thank you, sir, for that very insightful talk. Next, we have Dr. Sahana Shankar. She's a consultant pediatric gastroenterologist, hepatologist, or transplant specialist at Masundar Shaw Medical Center. Thank you so much for being here, even with your difficulty right now.
Thank you, Dr. Aditi, and good evening, everyone. I'll be speaking to you on when to refer a child for liver transplant and what are the outcomes of pediatric liver transplantation. This will be the outline of my talk. It is always said that the beginning is always a good place to start. And the story of transplantation began with this gentleman, an American surgeon scientist, Dr. Thomas Starzl, who's regarded as the father of transplantation. He very famously said back in 1982, what was inconceivable yesterday and barely achievable today often becomes routine tomorrow. This is perhaps true of liver transplantation as it is of several advances in medicine. A bit of this was covered by my colleague, Dr. Vinay, but I think the history of medicine is always fascinating. After several years of working on canine liver models, Dr. Starzl attempted the first human liver transplantation in 1963 on a 3-year-old child with biliary atresia and end-stage liver disease. Unfortunately, this child did not make it. He bled intraoperatively, and Dr. Starzl later wrote in his memoir, The Puzzle People, nothing we had done in the past could have prepared us for the enormity of this task. And subsequently, there were several such early failures. And critics and skeptics seem to say liver transplant seems like a fantasy, it's impractical. So the community themselves went on a self-imposed moratorium for about 4 years, went back to the surgical lab, worked more on immunosuppression, and came back in 1967. And the first successful liver transplant was done on a child, a 19-month-old child with biliary atresia and HCC. And this child went on to survive for about 19 months. The success following this was not only in part due to evolution in surgical techniques, but also due to evolution and improvement in post-transplant immunosuppression. And this was with the advent of cyclosporin in the 1970s by a British surgeon, Sir Roy Kahn. And in 1983, after about 540 liver transplants across Europe and North America, the NIH consensus meeting finally said that liver transplant is no longer an experimental procedure and should be recommended for all patients with end-stage liver disease. The golden era of liver transplantation was in the 1980s and 90s with the advent of tacrolimus, which has continued to remain as the backbone of post-transplant immunosuppression in solid organ transplants. So what about pediatric transplant in India? So the first pediatric transplant was performed 25 years ago in 1998, and subsequently we've been growing in leaps and bounds. We've done combined liver kidney, domino transplants, auxiliary liver transplants, and ABO incompatible liver transplants. So as of 2024, as per NOTO, there are 193 approved liver transplant centers, 25 of which are in our state, Karnataka, and in fact, in a period of 4 years, the numbers have doubled from 12 to 25. But pediatric liver transplant work continues to remain restricted to fewer centers across the country. I might skip this because we have covered the different types of liver transplant, but I just want to say a word about domino liver transplant and auxiliary liver transplant, because this is quite unique to children. Domino liver transplant is basically a way of expanding the donor pool. You take a child with metabolic liver disease, take their liver, which is structurally normal, but just has an enzymatic deficiency, and use that liver when the child undergoes a transplant for his own metabolic liver disease and implant it into another child with a different metabolic liver disease or end-stage liver disease due to other cause. So the idea is you choose a metabolic liver disease which has enough enzyme being produced in extrahepatic tissues. So when you implant this liver into another child, they will not have the same metabolic defect, but they will get the liver function that they did not have previously. So this has been done in India as well, and is being done across centers in India. Auxiliary liver transplant is also another very technically, surgically challenging procedure where you retain a part of the native liver, which is failing, and implant an auxiliary liver graft. This is usually done in an acute liver failure, where the idea is if you give the native liver enough time, it's going to survive. And during that time, you support it with an auxiliary liver graft. The idea is you might be able to withdraw your immunosuppression and allow the patient to live a life free of immunosuppression. So what are the indications of liver transplant in children? I think Dr. Vinay also alluded to this briefly. The standard indications of liver transplant in adults would be fatty liver disease, alcoholic liver disease, viral hepatitis. None of this is seen in children routinely. So the indications of liver transplant in children are very distinct. Often, the chronic liver disease that affect children are cholestatic to begin with. This is in contrast to adult liver diseases, where jaundice is usually a late manifestations because they have a hepatocellular liver damage. So the prototype of cholestatic liver disease in children is biliary atresia, and that's the commonest indication for liver transplant in children. You have genetic intrahepatic cholestasis syndromes, Alagille syndrome. The next big chunk is metabolic liver disease. We'll talk a bit about that later. Liver cancer continues to remain an indication in children, but here the common malignancy we see is hepatoblastoma, and not all of them require liver transplant, but when they're unresectable, they require liver transplant. HCC again is seen in very distinct metabolic liver diseases. Pulmonary vascular disorders like hepatopulmonary syndrome, portopulmonary syndrome, these are complications of long-standing portal hypertension. Another unique thing in children is they can have aberrancy malformations or congenital portosystemic shunts, which may present primarily with hepatopulmonary syndrome, which warrants a liver transplant. And then you have acute liver failure and decompensated chronic liver disease. I want to spend a little bit of time talking to you about biliary atresia because it's the commonest cause of liver transplantation in children. So it's a progressive cholangiopathy of an unclear cause and starts very early in life, either intrauterine or very early postnatal. The unique hallmark of this dreaded disease is its rapid progression to fibrosis, cirrhosis, and portal hypertension. I'd like to draw your attention to this graph, which is basically, how do I point? Okay, I'll probably just point with the. Can you see that? I'm sorry. So I'll just talk about it. So this is basically a graph that is showing liver stiffness measurements across age when the when babies present with biliary atresia. The blue band refers to normal liver stiffness, and as you can see, when babies are as young as 45 to 60 days of life, they have advanced fibrosis. By the time they're 90 days of life, they have frank cirrhosis and portal hypertension. So this just tells you how quickly they progress to end-stage liver disease and how diagnosis of biliary atresia is very time critical, because we have a very short time window where you can intervene and halt the progression of fibrosis. And that is done by a surgical procedure called Kasai portoenterostomy, where we remove or excise the atretic biliary tree and form a conduit to connect the small intestine directly to the liver with a Roux-en-Y jejunal anastomosis. But the caveat is it has to be done under 60 days of life or under 90 days of life to get the best results. And what are we talking about when we say best result? We're talking 60% successful Kasai in some of the best centers, high volume centers across the world. So the thumb rule is nearly half of babies born with biliary atresia end up needing a liver transplant, whether they're treated or not treated with a Kasai procedure before their second birthday. And that's how dreadful this disease can be. So when do we consider a baby with biliary atresia for liver transplant? A large cohort of babies that come to us are missed BAs. They come with a late diagnosis at 6 months of life with end-stage liver disease. So they need a primary liver transplant. Or they could be a failed Kasai. They've had a Kasai but have failed to clear their jaundice. Or they can present with significant portal hypertension, refractory variceal bleeds, symptomatic hypersplenism, refractory ascites, or they have cleared their jaundice but come back with fevers and jaundice and recurrent cholangitis. The other indications are quite common across the board for all chronic liver diseases like growth failure, refractory pruritus, HCC, metabolic bone disease, etc. I just want to talk to you about a few cases. All the pictures have been shared with the consent of the parents. This is a 10-month-old baby who presented to us, failed Kasai, very unwell with coagulopathy, ascites, cholangitis, and sepsis. This is her 3 months post-transplant, doing very well. She's now 2 years old and is a very delightful little girl. This is one of our long-term survivors. Also a biliary atresia post-Kasai, failed Kasai, presented to us at around 1.5 years of age. And she's now 10 years old. This is her at Durga Puja in West Bengal, 9 years post-transplant. Just a word about Alagilles. It's important to remember this because it presents just like biliary atresia, but often has extrahepatic features. So it's a genetic disorder, a multi-system disorder, but can present with cholestatic liver disease very early in life. And they have extra hepatic manifestations in the form of cardiac disease, renal anomalies, and that often becomes a contraindication to consider these babies for transplant if they have a very complex cyanotic heart disease, etc. So this baby here had a PDA and had a successful closure, but has a refractory pruritus. The other baby had peripheral pulmonary stenosis and is just being monitored and medically managed. This is another story of a baby with Alagille syndrome, but in fact was referred to us as a biliary atresia post-Kasai, failed Kasai. This was the child at 1 year of age, severely malnourished, deeply jaundiced. And when we looked at her, the growth failure looked disproportionate to the degree of liver disease. And when we did further genetic evaluation, she turned out to be an Alagille. The reason I mention this case is Alagilles do worse when they have a Kasai procedure. Their survival with native liver is much lower. And the other thing to bear in mind is it's only going to cure the liver disease, but the child is continue to have growth failure. You need to monitor them very closely for renal complications, etc. This is her 4.5 years post-transplant. I'll have to run through the rest of the slides. So the indications for other chronic cholestatic liver diseases remain the same as biliary atresia. I just want to spend a few seconds on metabolic liver disease because that is the next leading cause for liver transplantation in children, Wilson's being top on the list. It causes structural liver disease. So it causes a chronic progressive liver disease, so does tyrosinemia. But the other metabolic defects can be primarily restricted to the liver, where the maximum enzymatic expression is in the liver, and thus doing a liver transplant provides a surgical gene therapy. So it is curative. Whereas when there are metabolic liver diseases where there is significant extrahepatic expression, just transplanting the liver is not going to provide a cure, but it is going to improve quality of life and neurological outcomes, and it should be considered. When do you consider a child with Wilson's for transplant? This is very important because Wilson's is perhaps one of the few chronic liver diseases which is eminently treatable with chelation. But there are certain situations where you can't rescue them with chelation, and that would be end-stage liver disease when they have decompensated chronic liver disease unresponsive to chelation, or a patient who presents with an acute Wilson's. Often they have very poor prognosis. When not to transplant a Wilson's, this is important too. Primary neurological Wilson's do not transplant because just replacing the liver is not going to reverse the neurological symptoms, and it becomes more difficult for a family to manage a child with significant neuromorbidity on immunosuppression. This is another child with Wilson's, presented with refractory portal hypertension, 10 months post-transplant, doing very well. On sibling screening, the younger sister was also detected to have Wilson's, and she's doing well on chelation. Hopefully she'll avoid a transplant. A tyrosinemia child presented to the oncologist with pancytopenia and splenomegaly. On imaging had an HCC. GSD and tyrosinemias are notorious for developing HCC very early. This is a 13-year-old who presented with, had a diagnosis of GSD, chronic diarrhea, had multicentric HCC. So the difference between the previous one is this is a cirrhotic liver, right? You can see nodules. That's the explant. GSD does not result in cirrhosis, but it has a high propensity to develop hepatic adenomas, which then turn malignant, usually in the second decade of life or end of first decade of life. Severe short stature, primary amenorrhea, post-surgery, HCC-free, we've been able to do growth hormone therapy, and she's gained some height. Another very difficult child, hepatoblastoma, very sick child, had relapsed post-surgery, but continues to fight on and is very resilient. I'll probably rush through the ALF slides. I just want to make a point about ALF because if there is a predominantly adult physician audience, acute liver failure in children does not necessarily need to have encephalopathy. If you have coagulopathy, that's enough to call them as acute liver failures. This is important because encephalopathy is a mandatory criteria for adult ALF. And the reason this has been removed is because it's very difficult to identify encephalopathy in a young child. So the longer we wait, the more time is being lost. So if you have a sick child, check an INR, give vitamin K. If it's not improving, refer to a transplant unit because they're more likely to have better outcomes. It's very challenging to decide when to do a liver transplant because you don't have very good models. This is some data from our center, which shows that there was very good catch-up longitudinal growth post-transplant. These are the complications we have to look for. Long-term goals of pediatric liver transplant, I'll finish in the next 10 seconds. We need to ensure good growth and nutrition, good neurocognitive and psychosocial function. These are children who've been ill since birth. They've had minimal hepatic encephalopathy for a long time, so it's important to support them. Important to ensure good bone and endocrine health, adherence to immunosuppression, make sure they get catch-up immunizations, avoid live vaccines. Cancer screening is very important. These are children at risk for post-transplant lymphoproliferative disease, and promotion of safe living. And for a pediatric hepatologist, our ultimate goal is to safely transition these children to adulthood. So the way forward, it's very important to improve pre-transplant care. Early diagnosis is important. Nutritional rehabilitation goes a long way. Ensure immunizations are done. Improve organ donation so we can have a robust donor management and organ allocation systems. Innovative surgical techniques for expanding the donor pool. Often children suffer when they have a cadaveric waiting list and don't have a living donor in the family. Improve post-operative immunosuppression. And our long-term goal in a pediatric liver transplant recipient is to ensure long-term meaningful survival. And this is not just absence, mere absence of disease, but it's also to have reasonable physical, mental, and social well-being, allow them to complete school, make them employable, and have social inclusivity. Thank you all for your kind attention. I want to thank all the families who so graciously shared pictures of their children. They did not insist on anonymity, and I think their aim is to increase the awareness of transplantation and how transformative it is. Thank you all.
Thank you so much for that beautiful talk and sharing those lovely pictures. That was really heartwarming. Next, we have Dr. Manoj Singh. He's a senior consultant and the associate director of liver transplant and hepatobiliary surgery at Mazumdar Shaw Medical Center. Dr. Manoj Kumar Singh will be talking to us about liver transplant outcomes at NH.
Good evening, everyone. Thank you for being here. I'll just go over the outcomes across our network. This is our team. We are a team of 7 surgeons, 6 anesthetists, 2 hepatologists, 2 pediatric hepatologists, and we have 4 transplant coordinators and nurse practitioners. Our scope of work, we do living donor transplant, both adult and pediatric, deceased donor transplants, and HPV surgery. This is just a quick slide to show you how LDLT is done. So in living donor liver transplant, we remove the whole deceased liver and then the partial liver. It could be a right lobe, a left lobe, or in children, it is the left lateral segment. This is just a picture of deceased donor. It's a whole liver replacement. So you get a full deceased donor liver, and then you replace it in a recipient. So this is our liver transplant data over the last 5 years. We have done close to 300 transplants throughout our network, close to 100 in MSMC. Then we have a center in Gurgaon. We have done more than 100. We have one in Calcutta, and then we have a specific children's hospital in Mumbai. We have done close to 25, and then there are 2 small centers in Jaipur and Dharamshila. So we have done a total of 282 transplants, among them 50 are pediatric, and then 232 are adult. So deceased donor are around 10%, close to 10% of our total numbers. 90% is living donor. We have done 2 combined liver kidney transplants. Both are living donors. We had 2 separate liver and kidney donors for the same recipient, and 1 deceased donor pediatric split transplant. These are the indications for the adult patients. So most of them are, right now it's ethanol, between ethanol and NASH, and half of them are cryptogenic. There's no diagnosis for them. Viral etiologies are coming down, and then you have the indications spread over, autoimmune, Wilson's, and SPC. Very few acute liver failures. These are pediatric indications. I think Dr. Sahana has gone over them. So biliary atresia is the most common indication. After that, we have metabolic diseases. And then you have autoimmune and HCC. So these are our outcomes. In adult, we have close to 90%. So it's 87% 1 year survival, 70% 3 year, and 70% 5 year. So comparing it to the US data, they have 93% 1 year survival, 87% 3, and 80% 5 year survival. In pediatric, we don't have, I mean, we're still following up the patients. So 1 year survival data we have, it's 90% at 1 year. So compared to the SRTR data, they have 94% 1 year, 92% 3 year, and 90% 5 year survival. So complications, biliary complications are the most common. And then you have vascular complications. So we have close to maybe 4% vascular, 3.5% is arterial. Then you have portal and then hepatic venous. Published literature is around 5% for arterial complications, and then you have another 2 to 4% for portal and hepatic venous complications. Biliary published in literature, the complication rate is close to 30%. We have had a little less, maybe around 15%, I would say. In hernias, we have in our patients 7%. And rejection rates, acute documented rejections are in 7%. That is T cell rejection, AMR in 1%, and chronic rejection in 1.5%. The published literature is around 10 to 30%. Pediatric, we have little lesser vascular complications. It's 2% arterial, 4% portal. Published literature is 5% for both. Biliary complications, both leak and strictures, 15% in literature. So we have 4 and 4%. Rejection rates are 8% for acute and 2%. That is acute cellular is 8 and AMR is 2%. Chronic, we have to still follow up these patients. Oh, thank you.
Thank you so much for the talk. I'd like to request Dr. Vinay Kumar, Dr. Vidyadhar Maitri, and Dr. Sahana Shankar to please come to the stage as well. And we'll have hopefully an interesting discussion and any questions from the audience, please.
Pasha.
Fantastic number and presentation, or it was really learned from you guys. My question is, when you said 70% 3 year and because we are above diaphragm and you are below. So just as a curiosity, what is the reason for mortality in your patients at 3 and 5 years?
Long term, we have seen, I mean, long term, most of them they die because of, chronic complications related to chronic rejection. So a lot of these patients, some of them are lost to follow up, and the other ones, they, tend to stop taking they stop their medications, and then they will come with chronic rejection. And in the process of trying to treat them, you pulse them, they don't respond, they develop secondary complications because of immunosuppression. So they have, their livers, they stop responding, they go back to chronicity, and when you try to treat them, they get some second infection, mostly fungal or in the acute phase bacterial infections. You have any input?
So one more thing is that the point here is most of the Indian patients, when compared to US data, there the robust DDLT program is quite good. And in our centers, it's mostly LDLT. And often the patients, when they are transplanted, they are often nutritionally compromised at the higher end of MELD scores. And those patients usually fare little less compared to the early MELD score or nutritionally well patient prior to transplant. So usual complications related to the even the post transplant also, the nutrition is not going well, and they often catch some of the other infection and they end up in problems. And during those infections, as Dr. Manoj said, the immunosuppressions changes and all those things can lead to this complications later on.
And some of those late deaths are recurrence of primary disease also. So if we had patients transplant for HCC who come back with recurrence maybe 2 years beyond or at 3 years also. So we had, I think, 2-3 patients who have had recurrent HCC, and that's because of that. And some patients have had recurrent, if you have Hep B has been rare, but if they stop their medications, then they can have recurrent disease. Hep B or autoimmune patients also.
One more thing is the metabolic causes which adds on. The Indian patients are often having more incidence of diabetes post-transplant that is associated with immunosuppression, and also the cardiovascular complications later on add on to these list of causes of death in them.
Yes, ma'am.
Yeah. I frequently get complaints on very poor organ transplanted in DDLT. And the most common sentence used is the harvested liver was not of good quality, but for monetary benefits, the transplant center did the transplant. So if at all, if you suggest what is the single indicator I should collect from the transplant centers?
Indicator for?
For post transplant.
So DDLT in our most, the percentage of deceased donor, living donor varies from center to center. So we have only say 10% we do deceased donor, 90% is living donor. So that metric, if you're looking for just a metric for deceased donor, then you have to
like 1 month survival rate or after 6 months or 1 year.
So you can look at early transplant survival, that is 30 days survival.
Yeah, exactly. I'm collecting the same.
30 days survival or 1 year survival. So immediate, if you're just looking in deceased donor, if you're looking at outcomes because of poor graft, so that will show up in the early early mortality. So it will be like a 30-day survival or graft and patient survival. You can look at that.
Thank you. I'm monitoring that.
Another question. We always envy the liver. It's such a robust organ. So in disease program, do you still do HLA testing or still you are just keeping a close eye?
No,
don't look.
Even in living donor, we don't do HLA. Yeah. So it's just
such a robust organ.
Blood group matching. Yeah. So even that's why even if, because liver is it's what you call it's a sink, immunological sink. For combined liver kidney patients, also the requirement of immunosuppression is actually less than what you do for kidney alone.
Correct.
Same thing. Leverage organ, it will be, adds on to the amount of immunosuppression is also less, and the less immunosuppression we can achieve better success with those.
Same thing in when we do simultaneously lung and liver, you have to reduce the immunosuppression because they don't get rejection and all. Thanks.
And there is a proportion of patients who can even withstand systematic withdrawal of immunosuppression. And that's being increasingly done in the US. They identify selected patients who have never had rejection, who are on monotherapy, very low levels of immunosuppression, and gradually withdrawn, and they have done well. without much long-term graft fibrosis. So liver is a fantastic organ to transplant and look after.
The recent paper has shown uh, some points like the early rejection but very minimal rejection in case of mild rejection. These patients fare well compared to those patients who have complications and traumatic post transplant course. So those patients we always have a better success, and also especially in younger pediatric patient, the withdrawal of drugs also can be achieved. So because they are much more better without transplant medications in the later years.
One of the things that really struck me is that you have impressive numbers across the country. And I think as a team that deserves congratulations. So what is your secret to being able to maintain such a robust program in so many different cities, right? From referral and evaluation. And the most important is meticulous follow-up. So how as a team are you able to achieve that in so many different centers?
We have, set protocols, and most of our centers follow those protocols. So we have made those protocols, when we started, we sat down and we, made those protocols. So we have protocols for pre-transplant care, pre-transplant evaluation, then even the, surgical protocols we have. All those, so setting protocols is important when when you are spread out, and you have protocols for post-transplant care and follow-up also. So, and then there is sharing of information, so you follow those protocols and you share and among the whole team, then it becomes much easier.
Their families, how much time they stay in one center and how much they rotate. It's a lot of hard work and sweat.
And Dr. Vidyadhar, maybe you can talk a little bit about ICU management. I think that is a really key, phase post-transplant, making sure that the transplanted organ, functions nicely. And how have you instituted protocols in so many different centers? Doing it in one center is hard enough, but doing it in multiple places.
No, same as Dr. Manoj already told. It's a pre-op evaluation. How the patient behaves post-operatively, it mainly depends on how you have prepared them. If your preparation is good, you are already at 30%, 40% of the work is already done. And then remaining 20 to 40% is done, and the surgery is smoothly. So by the time patient comes to post-op, it is already taken care of. So then in the post-op period, two main problems which we face frequently is, one is heart related in the immediate post-op, I'm saying. Second is kidney related. So, and this team, like lung also. Lung also. So, I mean, you follow the protocol, and as Dr. Manoj said, you involve specialist at every step. So I would say that's a.
Even the other team, like pulmonary team, cardiac team, nephrology, they help us a lot in these management. And we have a set of streamlined protocols. So if we are going anywhere if you are finding any problem, you always approach and we try to rectify it the earliest. So then success is always depends on early identification and treatment. So this is helping us.
I think a lot of it is just experience. We have learned with experience, and then with that we have the identity. I think the goal is to identify the problem before. Pre-identification is important. So once we do that, then it's easier to implement the treatment protocols earlier rather than wait for a complication to happen. Preemptive treatment is very important in transplant. Because patients don't give you a big window. The window is very small. So if you catch it earlier and you start, your treatment, then, they do well.
Any other questions from the audience? With that, I'd like to thank all the doctors for an engaging discussion. I'd like to give a memento of thanks to all the speakers. I'd like to call Dr. Basha Khan, please, to give a, sorry. First to Dr. Sharad Damodar. To Dr. Vinay Kumar. Dr. Vidyadhar Maitri. Dr. Sahana Shankar. And Dr. Manoj Kumar Singh. Next, we'll have the session on kidney. To start off, we'll have Dr. Ganesh Srinivas Prasad talk about why kidney transplant, what are the indications. Dr. Ganesh is a consultant nephrologist at Mazumdar Shaw Medical Center with a vast experience in transplant nephrology.
Good evening, everyone. Today, I will talk about, in brief, about kidney transplant, why, when, and how to do the transplant, means what's the workup and how to carry forward. So first, today outline will be in the history of kidney transplant, indications and contraindications, pros and cons of kidney transplant, types of kidney transplant, basics of transplant immunology and immunosuppression, and outcomes at NH in brief. So coming to the history of kidney transplant, this is the image showing first successful kidney transplant surgery happening at Boston Hospital by Professor Joseph Murray. That's happened in 1954. The history of transplant goes back to 1900s, in the early 1900s, where initial workup is done on pigs and animal models, and then there are multiple attempts were done which were failed, but the first successful breakthrough happened when there is a identical HLA, identical twins in Boston by Joseph Murray. After that, in 1958, when the HLA, the molecular antigens were identified by Jean Dassett, and in 1960, the mercaptopurine was introduced in uses of transplant patients as a part of immunosuppression along with the steroids, which was later replaced by azathioprine and then followed by MMF. In 1969, there is a breakthrough in prevention of acute rejections in kidney transplant. From the 1966 itself, Professor Terasaki and Roman Patel were doing a job on the cross-match techniques, and they published a paper in 1969 which showed the importance of doing CDC cross-match to prevent hyperacute rejections. Later, after adopting this technique, there is a significant reduce in the number of hyperacute rejections in the post-transplant period. Later, 1978, when the CNIs, the first CNI, that is cyclosporin, is introduced in transplant, which was later recently in 80s, it was replaced by tacrolimus. In the 1980s, the monoclonal antibodies, the current one, basiliximab, and the previous one, daclituzumab, was used. And in 1985, the other induction agent, which is more commonly used, the OKT3, was introduced, but it was had a significant complications, which was later replaced by much safer profile drug, ATZ, and other drugs. The most recent timeline in organ transplant is the xenotransplant, which happened in this year with usage of genetically modified pig, and patient was there almost for 2 months without requiring dialysis. unfortunately, we lost him recently. We don't know the details about the details. We are yet to get the details, but this is a further step into the kidney transplant with a xenotransplant. So coming to the indications, as we all know, the major indication is end-stage kidney disease or CKD stage 5, when patient's GFR falls less than 15 ml per minute per 1.73 meters square. Very rarely in cases of severe resistant nephrotic syndrome, especially in children with severe congenital diseases where patients are not responding because of genetic this thing, we can do medical nephrectomy and then go for a renal transplant. So this is the major two indications, but coming to the contraindications, as we saw in the previous slide, how the science evolves, even with the contraindications also, we have the significant evolution in the science. That's the beauty of the science. So previously there were used to be a lot of contraindications for kidney transplant. I think now the contraindications, including previously there used to be even age is also a contraindication for transplant, but now age is just a number. It's not no more a contraindication. Similarly, various other associated organ like previously presence of heart failure or presence of severe liver failure used to be a contraindication, but now with we can use combined liver kidney transplant and combined heart kidney transplant. So those are not no more a contraindications. The major contraindications are severe frailty based on the survival and post-op tolerance of the patient, immunosuppression tolerance. The infection profile risk of the patient depends on this. We can consider the frailty is the main contraindication. Along with that, active or recent malignancy, based on the malignancy types like solid organ and blood malignancies, the duration varies from 2 to 5 years for the waiting period after treating the malignancy. Severe neurocognitive deficits with uncontrolled active psychiatric illness or active substance abuse, these are the contraindications. Active age defining illness is a contraindication. Previously, serological diseases, virological diseases like retrovirus and hepatitis C, hepatitis B were a contraindications for kidney transplant. Even as late as 2000, before 2017, before introduction of direct viral acting agents are available, even the hepatitis C was a significant contraindication. But now with the advent of direct viral acting agents, we can take the even patients with disease positive also. Whenever there is a disease donor is there, and if he turns out to be HCV positive, then there is no need for hesitation for doing a transplant even in a HCV negative donor, because DAS at the time of transplant we can start the patients on DAS, and there is enough evidence showing that we can safely do the transplant without wasting the organs just because patient is hepatitis C, donor is a hepatitis C. So coming to the pros and cons about kidney transplant. So the pros is mainly compared to the we have for end-stage renal disease we have only two options. One is dialysis, other is transplant. Compared to dialysis, the pros are long survival rates, better quality of life in terms of physical, emotional, and social well-being, and also it has compared to less cost compared to dialysis. To be on dialysis, the transplant is much less cost when we see in cumulative terms. So these are the various graphs showing significant. Sorry. So the first graph is showing the survival graph, Kaplan-Meier survival graph, where the patients who are on transplant, which has this is showing only living donor transplant, which has a significant survival benefits, whereas by 10 years, the mortality is significantly increased in dialysis patient. Similarly, in various studies, it has shown the transplant, even though initially it is high cost, but over a period of time, when the maintenance immunosuppression also caused the cut down, so the overall the maintenance of transplant is much cheaper compared to dialysis. As on dialysis, it is like doing a recurring deposit, and we have to keep paying EMIs. So the EMIs never end. The amount will be double, as because patient will develop more vascular access problems or CKD, MBD, other organ failure, heart failures will be there. So there will be more hospitalization risks. So the overall spending will be more in hemodialysis compared to transplant. This is the some studies showing the how the prevalence of CKD is improving and the transplants in European and American, and the mortality benefits compared to living hemodialysis, peritoneal dialysis, and kidney transplant. It has been increasing over a period, but always the mortality benefit is very much seen in the patients on liver kidney transplant compared to hemodialysis or peritoneal dialysis. So coming to the cons of kidney transplant, the most important side effects is the graft rejection. We can see previously we used to see, as I said previously, with the before invent of the sensitizing cross-matching techniques, there were cases of hyperacute rejections. But now with the availability of cross-matching techniques, we don't see any much hyperacute rejections, but we definitely see even acute rejections and this thing. Infections, again, based on the immunosuppression, based on the high risk profile, recurrence of native kidney disease is a problem. Again, malignancies because of immunosuppression, skin and other tumors are most commonly we see. New onset diabetes mellitus after transplantation. So I will just brief about immunology of transplant. So this is Professor Taraski working on cross-matching techniques. Coming to the immunology part, we need HLA typing. The better HLA match, the long-term survival of the graft is better. Even the HLA mismatch also we can do, but there is a slightly reduced graft survival. Similarly, this is for HLA match. Next is the cross-matching techniques for the graft acceptance. So CDC, which is the main cell, which is a cell-dependent cytotoxicity. These things will be spoken in detail by Dr. Ankit Mathur in the next coming talks. So CDC, flow cytometry, DSA, single antigen B test, these are the available cross-matching techniques. So presence of CDC positive is a definitive contraindication for kidney transplant. Coming to the immunosuppression, we have induction agents with depleting and non-depleting agents, rituximab, and maintenance. Mainly the main pillars for success of transplant is maintenance regimen with the standard of steroids, MMF, and tacrolimus. In few conditions, belatacept is also used, but it is not available in India. So coming to the types of kidney transplant, most in India compared to Western world, sadly we are doing more of live donor kidney transplant compared to deceased donor kidney transplant. The deceased donor kidney transplant is only around 10% of our total kidney transplant pool across the India. Across the India, around 7,000 transplants is happening. Around only the number of deceased donor is comparatively very less compared to the living donor. So in living donor, we can do ABO incompatible, which is much more common and safe and less risk. Whenever ABO compatible is not possible, we can do ABO incompatible, and we can do HLA sensitized where patient has cross-match positive against the donor, except for CDC. If other cross-match is positive, then we can do, which will be talked in detail by my colleague Dr. Vinod in the next talk. So deceased donor kidney transplant, we all know the waiting list is very high, and we have to increase the awareness about organ donation to cut down. But in the recent years, actually, to say after COVID, the numbers has significantly increased, and last year Karnataka is the top state among south states, which is the doing highest number of deceased donor transplant. So along with that, we can do combined organ transplant with liver, heart, and pancreas. So outcomes at NH, the first kidney transplant happened at NH in 2006. Till date, we have done more than around 700 to 800 kidney transplant. In last 1 year, we done around 58 transplants. In that, 24% are deceased donor and 5% are pediatric transplants. So there is no donor mortality in terms of living donation, these things. It is all done by laparoscopic technique, the donor nephrectomy. We had two graft lefts, that is 2 graft lefts out of 58, mainly because of hyperacute resections and in the post-op period within 15 days due to sensitized in the case of deceased donor, and we had for mainly for infections. With this, I will end my talk. Thank you.
Thank you so much for that very interesting talk. Next, we have Dr. Vinod Nagesh. He will talk about insights into high-risk kidney transplant. He's a consultant nephrologist at Mazumdar Shaw Medical Center.
Thank you, ma'am. My colleague, Dr. Ganesh, has already given an introduction on the overall aspects of kidney transplantation. I will just focus on the high-risk kidney transplants that we have done at NH. So what do you mean by high risk in kidney transplant? So it can be because of the recipient factors, donor factors, and immunological factors. So the recipient factors could be because of the comorbidities the patient has, the diabetes, peripheral vascular disease, the poor cardiovascular disease. And the donor factors, whenever the donor quality of the kidney is not good, still we take it, like marginal kidney donors in the form of low donor GFR, diabetic donors, elderly donors, hypertension. Recently, marginal donors transplantation has increased because to expand the donor pool, kidney donor pool. So today I'm going to talk about the immunological factors, where we are going to cross the immunological barriers and do transplants like ABO incompatible, HLA mismatch transplant, and transplant in sensitized patients. So what are the possible risks of crossing this immunological barrier in kidney transplantation? There is increased risk of hyperacute and acute rejection, and need for higher immunosuppression because already there are pre-existing antibodies, and increased risk of graft loss because of the infections as well as because of the rejection, and definitely increased risk of infections. So the question is, so much of risk is there, is it worth taking the risk? So definitely yes, because kidney transplantation better quality of life compared to dialysis. And when we compare to, as already Dr. Ganesh enumerated, disease organ donation constitutes less than 10% of overall transplants, kidney transplants in India. And the waiting time for cadaver kidney varies from 2 to 5 years. So there was a progressively increasing gap between the number of available organs for kidney transplantation and the number of patients who are waiting for the transplant. So the mortality of patients, dialysis patients on waiting list is progressively increases as they keep waiting for the transplant on dialysis. So if the transplant as early as possible, like for example, preemptive transplant, as and when before the patient reaches the dialysis, has a better outcomes compared to a patient who is waiting on dialysis and goes for a transplant. So now, because of the availability of better methods of detecting and characterizing the anti-HLA antibodies, and a better understanding of the molecular mechanisms of ABMR and availability of effective regimens, we are able to cross these barriers and give a meaningful outcomes. So this is a graph showing the most best accept is a willing and a compatible donor, which has equal good outcomes. The next best approach, when there is no availability of compatible donor, is a willing and incompatible donor. And the next is the waitlist compatible donor and no transplant. So progressively the outcomes are going to increase So definitely compared to the no transplant or waiting on dialysis, going ahead crossing immunological barrier is worth. I'm going to briefly give us a few case details which we have done. This case number 1 is Mrs. NP, 34-year-old female. She is a dialysis initiated in April 2021. Hypertension, basic disease, suspected chronic interstitial nephritis. She had a history of 2 units of blood transfusion a couple of months before the transplant. And she had 2 pregnancies, both vaginal delivery. So mother came forward for donation. She's HLA haplomatch. We got the cross match done. CDC cross match is negative. So DSA lysate cross match showed class 1 borderline positive. So this patient is sensitized. So what is sensitization? Development of HLA antibodies following exposure to non-self HLA antigens. So that can be because of the blood transfusions, previous pregnancies, and prior kidney transplant. So prior kidney transplant has a high risk of sensitizations, especially when the patients are going for second and third transplant. So we assess the sensitization or a preformed donor-specific antibodies with CDC cross-match, flow cross-match, and DSA assays. And then it also helps us to do virtual cross-match. So this patient, we got the HLA typing done. This is the patient details. And this is the donor HLA details. This is the donor-specific antibody details for which they had the antibody titers were maximum was 17,341. So we did a virtual cross match. So we identified the antibodies against donor HLA antigen. The one antigen, the B52, she had a MFI of 10,291. So it's a single HLA antigen with a high MFI. We decided to go ahead to desensitize and go ahead. So the desensitization protocols have changed over a period of a time. Initially, it used to be splenectomy with a lot of complications. With the introduction of rituximab, now we have moved to rituximab followed by plasmapheresis and low-dose IVIG. So for this patient, we gave rituximab in the 3 weeks prior to the transplant. 2 weeks prior, we started them on tacrolimus and MMF. We gave her 5 sessions of Plex plus IVIG. So on the day 0, with the induction of ATG 100 mg and methylprednisolone, we went ahead with transplant. So post-transplant, she went well. She improved achieved normal graft function. But in follow-up at 2 months, she had acute graft dysfunction, graft biopsy suggestive of antibody-mediated rejection, received 3 sessions of Plex, she improved. Now she has completed 6 months of post-transplant, creatinine maintaining at 1.2 on stable dose of maintenance immunosuppression. So when seeing data, desensitization in HLA incompatible kidney recipients when compared to patients who are maintaining only on dialysis is definitely their outcomes are good. So even they have seen some centers have gone ahead even with CDC cross-match positive also they have done desensitization with very high risk of antibody-mediated rejections. And even in those patients also, there was a survival benefit when compared to patients who are on dialysis alone. So the case number 2, another case is a Mr. N, 48-year-old male, is a diabetic hypertension, CKD stage 5. CKD progressed over 4 years to 11. He was not yet started on dialysis. So we gave a option of preemptive kidney transplant. His blood group was O positive and he had received no blood transfusion in the past. So when we was evaluated, he had no compatible donors in the family. Wife came forward for donation and her blood group was B positive. So for this step, we wanted to check the titers in the recipient against the donor's blood group and TB titers, which was 1:5 and 12. Regarding the anti-HLA antibodies, CDC and flow cross-match was negative. So this also patient underwent a desensitization antibody removal process, received rituximab of 500 mg 2 weeks prior, and 10 days prior was started on tacrolimus and MMF. So we used immunoadsorption column, selective removal of anti-B antibodies, received 4 sessions, titers was reduced from 512 to 1:4. With ATG induction, transplant was done. Patient had a brisk diuresis post-transplant, normal graft functions by POD5. And we did post-transplant antibody monitoring. Because of all immunosuppression, there was no rise. 1:8 did not require any plasmapheresis post-transplant. Usually, if they cross 1 month, because of accommodation, most probably lifelong monitoring is not required. Despite increase in titers also, graft rejection will not happen. So current status, the patient has completed 13 months post-transplant, normal graft functions on stable maintenance immunosuppression. So this is a meta-analysis which shows nowadays with advances and with expertise, a lot of centers have started doing ABO incompatible transplant, and the outcomes are comparable to compatible transplants. Almost in this meta-analysis, it showed 98% in compatible transplants and 96% in ABO incompatible 1-year graft survival. However, there was increased risk of infections. So nowadays, with we are even reducing the immunosuppression. We have gone down to rituximab 100 and 200 mg. Thereby, the infection episodes are also coming down. So in NH, for last 10 years, we have done around 55 ABO compatible transplants. So desensitization protocols are various. Some patients have received plasmapheresis and some patients have received immunoadsorption. So we have data only up to the 1 year post-transplant. So graft survival was around 94.5% and patient survival was 98%. So the best approach to these patients is always a paired kidney exchange when we have a two incompatible pairs so that we can exchange the donor with other recipient that make them compatible, even in ABO also, even in HLA sensitized patients also. So in the swab transplant way forward, it's the best way to convert incompatible to compatible transplant. So we are actually planning to develop a pan-India swab registry across all NH centers in India so that we can develop a software so that which automatically tells us which is the correct pair wherever it is in whichever center across the country. So as I told, ABO incompatible transplants have comparable outcomes. And live donor transplantation after desensitization provides a significant survival benefit. So better assays are available to characterize the anti-HLA and anti-ABO antibodies. And ideally, swab transplant is the ideal goal when the appropriate pair is available. If no, we can conveniently do the desensitization protocols and go ahead with transplants. Thank you.
Thank you for that talk. Next, we have Dr. Akhila Vasant. She's a pediatric consultant nephrologist at Mazumdar Shaw Medical Center. She'll be talking about cadaver kidney transplant and pediatric kidney transplant, the way forward.
Thank you, Dr. Aditi, and good evening, everyone. So I'm a consultant pediatric nephrologist. I'll be talking about pediatric kidney transplant and the cadaver kidney transplant. As many of you may know, that one organ can actually save a minimum of 8 lives, and that's amazing, isn't it? If you look at the transplantobservatory.org, website, which looks at the number of transplants which has been done all over the world, India actually is the third largest transplanting country in the world. Also because we have, rise in the lifestyle diseases, rise in the number of transplant centers, the governments and the NGOs, they're all working together to strengthen the disease donor program. And there's been introduction of the disease donor program in parts of the country which previously didn't have. So if you actually look, the number of transplants done in 2022 is about 16,000, and when we stand third in the world. However, so if you look at the number of people who are waiting for a kidney transplant, in Karnataka, it's about 5,942 people on the waiting list, and it's still growing. And in last year, we have done, Karnataka has done around 279 in total, out of which, 268 are pure kidneys, 9 of them are kidney and liver, kidney and pancreas are 2 of them, so totally 279. So if you actually look, there is an increasing trend of, disease donor kidney transplants. And this year already, we've done around 78 kidney transplants in Karnataka. So if you actually look at our websites, the State Organ Tissue Transplant Organization website, there is a QR code, and similarly with the NOTO website as well, there is a QR code. It's a very quick thing. You just go and scan the QR code, and it takes you, through these like a drop-down box. You just have to fill in your details and what can be donated. You can donate your heart, lungs, liver, pancreas, kidneys, small intestine, cornea, skin, tissues, and many other parts. But the important thing is, one is to be registered as a donor, and the other thing is you need to tell your people who are close to you, saying that you are registered as a donor, and they have to give permission or consent as well. So that's very important. So Karnataka actually ranked fourth, in the number of pledges. Third, is it? Okay, thank you, madam. Yes, Ballari is the highest. Yes, I've got that one. So Ballari district, ranks the first in India with 4,363 people pledging their organs. And in the NOTO website, roughly around 20,000 organ donation pledges have been done. And NOTO and SOTO put together, it's about 60,000 odd. So if you look at the process, it's quite, a long one. So first of all, you have to be registered as a kidney donor, registered as a donor. And then you have to be unfortunate to have, brain death. And then, you have to have doctors who can actually, certify brain death and then authorize the donation. Then comes the matching process, then comes recovery of the organs, and then the transportation of the organs. So if you actually look at this whole process, there can be a lot of problems in between. So the main barriers which we have is lack of organ donation awareness. There are many NGOs who are now promoting this, which is a good thing. And lack of awareness of the brain death concept. There are many small, hospitals wherein they could. No, there is a brain death, but then they actually don't know the process of, how this particular, patient could be a potential organ donor. And also you need to be registered as, you need to have a license, in order to process this organ donation thing. And also you need to be registered, in the brain death committee as well to certify brain death. And even if there are some, the few centers who do these, donor transplants, and if you look, the number of cadaver, transplant centers is still inadequate. And if sometimes the infrastructure is not great or the personnel is not great. So there are many reasons why a potential donor does not actually become a utilized donor. So because there could be problems in the system in terms of, failure of identification of the donor, or a brain that diagnosis is not made, or there could be logistical problems, or there could be a lack of, appropriate recipient as such. Or there could be problems with the donor as such, in the sense it could be unsuitable organs, or the organs when they're harvested, they could be damaged, or there could be anatomical problems in the harvested organs. There could be hemodynamic instability in the donors, and inadequate perfusion, etc. Or there could be problems in the permission, in the actual process. Wherein, the family members may actually refuse, consent or permission for organ donation, etc. So how do we move forward? I'm sure there are many others who have, had this vision, in the next decade of how to improve the disease donor transplant. So one is to simplify onboarding. So you can, Jivasarthakate can, grant ad hoc emergency licenses to the non-licensed transplant retrieval centers where brain death occurs to facilitate organ donation. Establish a brain death certification helpline, to have a hub and spoke model between transplant centers and the NTORCs. And to increase number of transplant coordinators and their education, and also address awareness and training. You must have heard of Mohan Foundation. This is an NGO. They do have these master classes on grief counseling. So you can invite them to your hospital, and then they can they can conduct some workshops in order to, first of all, identify some social workers who can basically speak to the families about organ donation. So it's, you can have, they generally do some lectures and role plays on breaking bad news, how to approach families for organ donation, and coordination of the MLC cases, difficult donation, challenging, cases, etc. So this is something you can literally just approach them, and they will do that for you. So who can be an organ donor? So in your hospitals, so say for example, if there is a deceased donor who is brain dead, and the standard criteria will be a deceased donor who will be who's less than 60 years. there are some extended, criteria for kidney donors. If a kidney donor is more than 60 years or more than 50 years with two or more than two risk factors like, hypertension, stroke, kidney damage, etc. We don't do disease cardiac DCD donation, and high-risk donors, I'll come to that in a bit. So if, say, for example, we have a patient who's brain dead and have normal renal function, no hypertension, no diabetes, no malignancies, no, generalized viral or bacterial infection, acceptable urine analysis, negative assays for syphilis, hepatitis, and HIV, they can be an appropriate kidney donor. The contraindications is if, say, for example, the donor has got chronic renal disease or oliguric acute renal failure, or more than 70 years, or has some metastasizing malignancy, severe hypertension uncontrolled, or if he's an intravenous abuser or untreated bacterial sepsis, then they are not appropriate donors. Expanded criteria donors, donors less than 6 years of age, you can do en bloc, transplants as well. And donor with age more than 60 years can be accepted only if the parameters are normal. And like I mentioned, donors between 51 to 59 years, if they have cerebrovascular death, hypertension or serum creatinine more than 1.5 milligram, we could consider them as expanded criteria donors. So how do we actually maintain them? The goals of donor management would be to maintain good systolic blood pressures by giving, colloids and, dopamine infusions, and to maintain a good urine output more than 50 ml per hour, to maintain a good, body temperature 34 to 36 degrees. And, if, say, for example, there's some metabolic abnormalities like hyperglycemia, bradycardia, you can treat that. So in the last 15 years, we have done around 52 cadaveric renal transplants, and the patient survival is about 93, 1 year patient survival, and 1 year graft survival is about 89%. So what's the way forward? So, enforcement of the disease donor programs, we need to have combined efforts with the health ministry, the NGOs, the private and the government medical colleges, get some financial aids from all these fundraising agencies, have good trained transplant coordinators, make some transplant legislations which are mandatory, and have newer surgical techniques so that we can reduce the mortality, morbidity, and the infections as well. Registries are quite useful in effective planning, and it's useful to have a National Kidney Foundation which can fight for the patients, and also implementation of the guidelines to have everything streamlined. So pediatric kidney transplants, it's important to know children are not small adults. So if you look, I'm sorry, I won't be too long. So if there was a paper written by Dr. Arpana Iyengar and Dr. Minion McCulloch. They looked at the developing countries wherein the outcomes of the kidney transplant, 1 year survival was about 90 to 98%, and 10-year survival was about 60 to 85%. So what are the challenges? The challenges in pediatrics is rejection, recurrence of the primary disease, progression of the kidney disease. You can have lots of infections, urine infections, especially because majority of them are caquot. They can have cardiometabolic problems just like in the adults. And in addition to that, they have growth and developmental problems as well. You need to understand that in children, it doesn't stop with one transplant. They need to have 2 or 3 transplants in their whole lifetime. So it's very important to make sure that the transplant actually lasts for a long time. And children have unique concerns in terms of, congenital disorders. And it's a lot of MDT work, which is required perioperatively as well as postoperatively. They're quite unique. We need to address the bladders. So if you if you transplant kidney in a bladder, it's going to pack up. So we need to have adequate capacity bladder, which has got good compliance. Sometimes we may have to initiate, clean intermittent catheterization and mitigate, infection risks, etc. In children, we do nephrectomy mainly if, say, for example, there's severe proteinuria, polyuria, in genetic syndromes, which can cause Wilms tumors, or chronic recurrent urinary tract infections, or PKD, etc. So what are the main challenges in pediatric renal transplants? So One is to find, make a decision between an old, well-matched living donor versus a young, poorly matched deceased donor. So, we need to take these things into considerations. It can be a large graft, which requires a lot of renal blood flow. So it requires aggressive fluid management. Hemodynamic challenges are there. And my colleague, Dr. Zamir will talk about, the actual surgical aspects and the challenges, urological workup, which is required. To fit an adult-sized graft in a small retroperitoneal space. But the main problem which we do see is, venous thrombosis and vascular complications, which are more common in children when compared to the adults. And of course, it requires MDT, workup. So at NH, in the last 15 years, we've done about 32 pediatric transplants, and the one-year patient survival and graft survival is about 95%. And the youngest we have done is 2 years, 6-month-old. He weighs 12.5 kgs. We've taken the consent of, these parents to show these pictures. It's been 2 months since he's been transplanted, and touch wood, he's doing well. So this is my last slide. So we need to work at different levels, at the individual level, the state level, as well as the national level, in order to increase improve the rates of pediatric transplants. The first thing is early detection of CKD and prompt referral, because prevention is much better than cure. And then obviously empowering families and parents on decision making, because majority of them, they actually, give up when it comes to transplants. And obviously, we need to work, together in terms of, along with the state and the policy makers as well, at, like I said, state and national levels, to make this a success in the future. So thank you very much. Sorry for the delay.
Thank you for that brilliant talk. Your insights on disease donation especially were really interesting. Next, we have Dr. Zamir. He is going to talk about surgical aspects of kidney transplant. He's a consultant pediatric surgeon at Mazumdar Shaw Medical Center with vast experience. Thank you.
Hi, good evening, everyone. After the 3 great talks on the medical aspects of renal transplant, I'll quickly take you across the surgical aspects of renal transplant. My talk will be on the preoperative preparation of the donor and the recipient, a brief overview of the basic surgical procedure, what is kidney transplant, what is it basically, or how do we do the surgery, and what's the way forward. Donor selection and evaluation, I think we have already heard a couple of talks about the importance of compatibility to find the donor, to find an appropriate donor for a recipient, and to make sure the donor is suitable for the recipient. Apart from that, the evaluation process for the donor, primarily the living related, would be to make sure the donor can undergo a major surgical procedure. So to make sure there's proper cardiac evaluation, pulmonary evaluation, psychiatric evaluation is very important, because we want to make sure that the donor is willing, he is in senses, and is giving a proper consent. From the surgical point of view, we are looking at the renal functions. You're looking at both the kidneys, you're looking at the GFR. You want to make sure that you're putting a good functioning kidney into the recipient. And you also want to make sure that the kidney that you're leaving behind in the donor is functioning properly. For the surgical point of view, the important aspect is with the vascular anatomy. What we want to do most of the time, it is the left kidney that we use for transplants, basically because the right kidney has a much smaller renal vein. So the transplant is more complex. So the left kidney is the general one that is taken. In vascular anatomy, we're looking more into the length of the renal artery. There are always variations. There'll be sometimes early branching, there'll be double branches, there'll be an accessory artery. So it is good to have a roadmap. There are certain donors who have multiple small vessels who may not be appropriate, who may not be a proper case for a donor. But this anatomy, a proper imaging is always a benchmark. We need to have it before we embark onto a surgery. For the recipient, I think again, it is who is the patient? Does the patient have renal failure? Does the patient require transplant? All that workup is done by the nephrologist. make sure they screen them for proper comorbidities to make sure they can undergo a major cardiac surgery, make sure they are well prepared with dialysis, they are not fluid overloaded at the time of surgery, to make sure their cardiac status is well taken care of, and also the psychological evaluation. As Dr. Akhila has just said, the bladder assessment, especially in pediatric transplants, is very important. In pediatric cases, most of the time, it is cases like a posterior valve or a neurogenic bladder in which the bladder is very small, it is high pressure bladder, and there's outflow obstruction. And this is the cause for renal failure in them. So if we do a transplant in them without taking care of the bladder and the outflow, then that would lead to damage to the, in due course, the transplant kidney also will get dilated and get under high pressure and back up. So that's the reason why first we have to make sure the bladder and the outflow is taken care of. There's no obstruction. We have to make sure that the capacity of the bladder is good. So many times in children, we have to undergo surgeries before the transplant, like a Mitrofanov to do a CIC. Sometimes we may have to do an augmentation to make sure the capacity is big, to make sure the pressure in the bladder is less, and then only undergo transplant. This can happen before the transplant or sometimes even during the transplant. Quickly, let's go across the surgical aspects. The donor nephrectomy nowadays is most of the places performed laparoscopically. It's a very nice, clean surgery. Laparoscopy gives us good view, gives us good access to the vessels, and a small incision in the lower abdomen is given so that it is more cosmetic and we can take out the donor kidney. Most of the time they're discharged within 5 to 7 days. The bench surgery, so once the kidney is out, we do something called the bench surgery. The surgery is done on a bench. The kidney is perfused with a fluid to protect it and placed on ice, and all the fat, gerotas fascia, all that is cleared. Vessels are cleared so that we can do the transplant on the recipient. The recipient surgery is heterotopic transplant, unlike liver, unlike heart, which are orthotopic. Heterotopic means basically we don't remove the previous kidney, we don't place the new kidney in the actual renal place, we place it somewhere most of the time in the right iliac fossa. So generally after the transplant, the patient goes back with 3 kidneys. It's a left lower quadrant incision, extraperitoneal approach, and we prepare the bed. Prepare the bed means basically creating space to place the kidney and dissecting the vessels. The vessels, basically what most of the time what we are looking at is, not sure if you're able to see it. Most of the vessels, most of the time it is this is the common carotid artery. And then we look at the external and the interiliac arteries. These are the arteries which are used for anastomosis with the renal artery, with the transplant graft renal artery. And the external iliac vein is the vein that is used for anastomosis. Sometimes we get 2 vessels, sometimes we even get 3 vessels. If the extra vessel is very small, inferior epigastric artery is also used. This is one of the transplant photos. The one on the left is shown the transplant kidney is covered with ice. We do the anastomosis here. The anastomosis is done with the common carotid artery and the external iliac vein. As soon as we release the clamps, the kidney is perfused. And the best part of kidney transplant is within a few minutes, you start seeing urine being produced. And once the urine is produced, you know that everything is well. You can see the kidney, you can see the perfusion, you can feel it, you can feel its turgidity, and you're happy. And then the next part of the process is reimplanting the ureter into the bladder. And once you see urine, as I said, you know, that's you're quite satisfied that the surgery has gone well. Challenges, as I said, most of the time you have 1 renal artery, 1 renal vein, and 1 ureter to reimplant. There are times we get multiple vessels. As I said, most of the time they are diagnosed preoperatively on the imaging, but sometimes you also get surprises. This one case, you can see 2 renal arteries, another accessory renal artery, another vein draining down. So both have to be implanted because many times there's not enough collateralization within the kidney. So we'll have to reimplant both the arteries, both the veins. This is one case we had, you see on the left side of the CT imaging showing there are 3 renal arteries. So all the 3 renal arteries have to be, and there's not much of collateralization. Each artery is supplying kind of separate part of the kidneys. So one has to do anastomosis to these 3 small vessels. So can be done, and once it is done, the kidney works well. They are associated more risk of complications like thrombosis, but if they are well taken care of, well heparinized postoperatively, the kidney works exceptionally well. Complications, every surgery has its own sets of complications. Surgical complications like bleeding, vascular thrombosis are known, but with renal transplant, unlike liver, it is much better, it is much less. You have bigger vessels, you have good flow across, so chance of thrombus and all is significantly less. Urinary leak also is known, but most of the time it settles on conservative management. As we said, again, kidney complications, post-operative complications are more to do with rejection, more to do with compatibility and infection in Indian scenario. What is new coming up in transplant? We don't know. Robot is invading all types of surgeries. The AI is invading all aspects, including medicine. So time will say how much of AI will start doing transplants and get into transplant status. The way forward, from surgical point of view, living related is the most commonly is being done in India. Almost 80, 90% of all our transplant nets are living related. It is good for a surgeon because it is actually the long-term survival of the kidney. The long risk of rejection is less. Also, the patient doesn't need to keep waiting for a long transplant waiting list. And all these living related surgeries are always planned. So you plan the surgery, you fix up a date, you properly evaluate the donor, you properly prepare the recipient. So the outcome is quite good. Unlike cadaveric transplant, disease donor transplant, in which it happens in random, it may happen at 2 o'clock in the morning, where you have to quickly bring the recipient in, prepare in a short period of time and do the surgery. Nevertheless, deceased donor has its place. There's a long waiting period for transplants, but this is the way forward, because as the previous talk had shown, there's a huge number of waiting list of patients for transplant. And if we have more pool, if we have more organ donations, it will definitely reduce the number. Many times there are no specific donors in the family. There are no compatible donors in the family. And most importantly, if we are undergoing a deceased donor, you don't have to subject a normal, healthy person for a major surgery like a nephrectomy. One last talk from, unlike other liver or something, kidney failure, we always have dialysis. We keep hearing a lot of patients that I have been on dialysis, I will go and get my dialysis done. Why should I go for a surgery? Why should I go for a transplant, which is a major surgery associated with complications of surgery, associated with long-term immunosuppression? But then there's a lot of studies which have come up which say that transplant improves the overall survival rate and improves the quality of life of all patients as compared to dialysis. If you take the overall cost of transplant and the overall cost of the frequent visits of dialysis, as was said in the previous talk, it has been found that the cost of dialysis comes out to be more than that of renal transplant. So I think transplant is the way forward for all patients with renal failure. Once a patient is diagnosed with renal failure, is on dialysis, they have to be, or maybe even before dialysis, they should be approached upon and should be consulted. They should be given proper information regarding transplant, and then let them take a call what's next. Our experience, almost nearing 600 transplants. Most of the deceased donors are about 10%. Graft and pediatric transplants about almost 40. The graft survival is almost 90 to 95% of this in all our patients. What do we as a team at NH bring to the table? We have a very comprehensive program. We have a state-of-the-art infrastructure. As you see, we have the support of multidisciplinary teams. We have the nephrologists, we have the intensivists, we have the cardiac people, we have the GI people. So anytime a patient has multiple problems, multiple systems, we have the support under one roof, and that's the reason why we are able to embark on complex conditions. We are able to take on difficult cases and get good results. Long-term association with patients, we have a good program. We keep a track of all the patients that we have transplanted and keep a regular follow-up. So that's what helps us to get good results. At the end, transplant is a big surgery. It is not possible by one person. This, if you look at this, it's a big team. This is just our team of renal transplants, in which we have the surgeons, the nephrologists, the intensivists. We have the administrators who actually give us support to do the transplants. And most of all, we have our residents around the clock in the hospital. And complex procedures like this is possible only if we have a good team support, and then we can deliver the good results. Thank you.
Thank you for that great talk. I'd like to invite all the speakers to come up for the question and answers. Dr. Ganesh Prasad, Dr. Vinod, Dr. Akhila Vasant, and Dr. Zamir.
India is the third in the world for the transplantation, as per your this one. What about the bioengineered xenograft? Where we stand, India stands. Because in US last month, March 16th, they did a big renal transplant. I don't know how India is prepared for that bioengineered big transplant, renal transplant. Even all other organs are on the pipeline. Liver, pancreas, all are in pipeline and genetically modified. What about India, where India stands?
So there are two aspects in it. One is bioengineered kidneys, another is xenotransplantation. So when the study like xenotransplant is started, there are a lot of hurdles in it, like the unusual infections and the rejection, other possibilities. Then they thought we can genetically modify the pig, grow in the lab and take that kidney and do the transplant. In a way, we can avoid a lot of immunological barriers. And that has been successfully done. And already Dr. Ganesh has enumerated in his presentation, it was done around 2-3 months back, and the patient successfully tolerated the procedure. He could leave without dialysis for 2 months. After that, we got the news that the patient has died. The reasons are not disclosed. We don't know. We are still not sure it is because of the transplant related or it is non-transplant related. Second thing, coming to the where India stands. See, in India, still no one has tried a clinical trial with whatever the transplant rates available. Regarding the xenotransplant, it is not yet done. And coming to with respect to the bioengineered kidneys, that's totally different thing where they're trying to grow the tissue or kidney within the lab in vitro from stem cells. That is still the research is in progressing, and I think we don't have a bioengineered kidney transplanted into humans.
Moreover, sir, bioengineered kidneys are genetical. What the xenotransplant is done, it comes with the not the regular transplant. The genetic modification, they have to first remove the genes in the pig, which cause some diseases in the human, like prion diseases and all. They have removed that, and then they modified some genes in the kidney, and the cost of that raising one pig for genetically it costs around 2 lakh US dollars. So when it again the new immunosuppression is not the routine immunosuppression they've used. The amount of immunosuppression they have used is very huge actually. The routine immunosuppression what we showed in the starting of the talk is actually many patients of our setting, they don't tolerate that much immunosuppression. What we are using actually, we use very less compared to the Western world, the amount of immunosuppression. So with that amount of immunosuppression, it really need, we have to be the hygienic capacity, hygienic conditions, overall our overall structure, not just the social structure has to be changed dramatically to actually come into the real picture. We can do xenotransplant maybe in future, maybe another 20 years or like that, but that numbers to grow more means with there should be a overall change, because our patients, I don't think they can tolerate this much of immunosuppression. This patient itself has lost in very few months, so our patients can't tolerate that much immunosuppression. They will succumb to infections.
Sir, during a donor nephrectomy, sir, one kidney is removed. Post-operatively, what is the immediate changes, biochemical changes, and how that single kidney is come to the normal levels?
Yeah, hi. Generally, if donor nephrectomy, when we do, we make sure that the other kidney is normal. We make sure we evaluate preoperatively to make sure the GFR is good. So generally, by doing a nephrectomy, there is not much of any metabolic or any biochemical changes in the patient immediately post-transplant. So we just have to make sure that we are giving adequate doses of medications. We are making sure the fluid balance is maintained. And if that basically is maintained, the other kidney immediately takes over the function of both the kidneys. So generally, they do well. They do just like any other patient who has undergone any other major surgery with one kidney.
Just to add to the question about xenotransplantation in India, actually in 1997, the first doctor to perform xenotransplant was in India. He transplanted a pig heart. It was not a genetically modified pig, so this was very controversial at the time, and that there were charges against him. But this idea originated, or India was one of the places where this idea of xenotransplantation actually originated. Yes. Yes.
Our DCGI is very strict. It will not probably permit even to use approved therapies outside of India unless DCGI approves, we cannot use it. So something in the trial phases, it's very difficult to do it. Yeah, what you are telling is true, sir. In maybe 10 years down the lane, we will probably doing a lot of it. But at this point of time, I don't think our even drug control DCJ is very strict with respect to any trials which are where we have some risk to the patient, it will not be allowed.
Even the liver transplant, pancreas, so many waiting list is there.
I think the immunosuppression in India is much different from that what we see in the West. He's been saying that, we cannot equate what is happening in US as same as that in India, because the number of infections that we see post-transplant is humongous. We see all types of viruses, bacteria, fungi. We see patients coming up after 1 month, after 3 months. So one of the major problem that we have in our post-transplant patients is infection because of the scenario that we have, because of the setup, because of the social circumstances that we have here. So I think immunosuppression, the idea of most of the time is to reduce the immunosuppression to come down as much as possible so that our patients can go into the general public and live a normal life. So for that, if we have to, it's preferable always to have a living related, preferable always to have a good compatible for kidney transplants and all that case.
I have a question about multi-organ transplant. What is your experience with, or your thoughts on how we can improve our approach to patients who require dual organ transplant, whether it's kidney and liver or heart and lung?
I think multi-organ transplants, we have a specific set of patients. First of all, we have to identify who are the patients who require this. And either, you have a liver and a kidney transplant. If you have a patient who requires both of them, they have to be worked up, one, for both the liver as well as the kidney. Secondly, they have to be counseled regarding the both. And it is very important for the patients to understand what they are getting into. Because, at one time you're looking at just the liver itself is a very complex surgery, just a kidney itself is a complex, and you're doing 2 transplants from the surgical point at least. The duration of surgery goes long, and there are a lot of other factors which come into play. And this is the time when, your multidisciplinary team is very, very important. All the departments, the nephrology, the kidney team, the liver team have to sit together, first of all, we have to sit and decide that we need to go ahead. When do we need to go ahead, and what are the preoperative evaluation that needs to be done? We need to make sure all that is done. And then we need to sit and talk to the patients about all this and make sure they are okay. So once that is done, then, most of the time it is a disease donor liver transplant, liver and kidney, or a combined transplant, and that definitely helps us out.
So hopefully this event will pave the way for more multi-organ transplants at our center in the future.
Yeah, I mean, I think the challenge which we have is that, say for example, in primary hyperoxaluria patients who require both liver and, kidney transplants, majority of them, we don't have donors who are fit who would give both their liver and kidney, and they end up, being listed under the combined kidney liver transplant program. So it is quite challenging. MDT approach is really very helpful. Yeah, we don't have many organs coming for our patients though, for the combined kidney liver transplant. So it is difficult. It's quite challenging.
You are based in Bangalore only, Dr. Zamir?
As of now.
Yeah. So I just want to give more insight. If a government transplant center have to take messages from centers like you, what messages you want to give?
Ma'am, I think if the government centers take up transplant, it would be one of the best things for the
It is
country.
taken, but I need more suggestions from you.
Ma'am, couple of things. One thing is they need to have good infrastructure, because transplant is one thing. It is not just surgery. During surgery, there are a lot of intricate surgical things, like you need to get good instrumentation, you need to get good sutures. If all that is there, and post-operatively, intensive monitoring. For that, they need to have facilities for a good intensive care. If that is available and you have a separate center, separate room, which they are not, the patients are not mixed with the general routine public, so that, the aspect of infection is taken care of, that would be very good one. Secondly, I think the second important thing is, you need to have good camaraderie among the people of different departments. I think, I don't know please correct me if I'm wrong, my personal feeling
It's a
is
perfect suggestion.
that is one thing that hampers. Everybody has their own
Yeah,
egos, and if that is taken aside and everybody sits together and talks, and I think it would be one of the best things for the country.
Yeah, and as Akila brought out, there are no pediatric transplants taken in government sector as of now in Karnataka. That's one of the backlog we are having. Yeah, and one major question, I don't know whether this dias is suitable, but still I want to ask you. Multi-organ transplant surgeons who are certified in America, other fellowships and all, are they not entitled to do kidney transplants? Or only urologists have to do the kidney transplants?
They can do.
Yeah.
Actually, in PGH Chandigarh,
Yeah.
that's not, there is a
In
separate
other states,
department,
it's not
just
the
a
mandate.
transplant.
For anybody qualified with multi-organ transplants, they can do the kidney transplants. Am I right?
Yes.
Yeah, that's a more wanted question for me to make policy. Because I've got many RTS regarding that, but still I can have a individual discussion with you. And Akila made the SOTO presentation very easy. Thank you so much.
I got in Victoria Hospital is doing liver transplant. Institute of Gastroenterology in Bangalore. They did about 50 to 60 liver transplant last 3 months.
Yes, even INU is also doing good number of kidney transplants, even within Victoria Hospital.
It would be great if maybe SOTO gives some preference to pediatrics, especially on the disease donor list. Oh, thank you.
Thank you.
Thank you so much for that engaging discussion. Now we'll break for a quick refreshment break. So we'll meet again at 7 p.m. Sorry, I'll just add this. Sorry, I'd like to call Dr. Murli Mohan to give a token of thanks to all our speakers. So, Dr. Ganesh Prasad. Dr. Vinod. Dr. Vinod. Dr. Akhila Vasan. Dr. Zamir. Thank you to all the speakers.
ಯಾವ್ದು ಇವಾಗ ರೆಕಾರ್ಡಿಂಗ್ ಆಗ್ತಾ ಇದೆ ಮ್ಯೂಸಿಕ್ ಹಾಕಿರ್ತಾನೆ ಇಲ್ಲ ಅದು ನೀವು ಲಾಗಿನ್ ಮಾಡಿದ್ನಲ್ಲ ಓಕೆ ನಿಮ್ಗೆ
I'd like everyone to head back inside, please, so we can start with the lung session. Our first speaker will be Dr. Murli Mohan. Dr. Murli Mohan is a senior consultant in pulmonology at Mazumdar Shaw Medical Center. He's had vast experience in the field of chronic lung diseases, particularly interstitial lung diseases. He's renowned all over the country, and he's had several papers in national and international journals. So with that, we'll start. Dr. Murli Mohan, sir, will be talking about treatment options in progressive ILD, including lung transplant.
So first of all, thanks to the organizers for giving me this opportunity. I'm really the odd person out. I don't directly deal with transplants. I just feed the transplant team. I deal with a lot of interstitial lung disease, but I'll be starting with a patient, 46-year-old male, a grocery owner from grocery shop owner from Tamil Nadu, who came to us with a very short history of fever and dry cough. But he also complained of breathlessness, which progressed from a grade 2 MMRC to a grade 3 MMRC over just 2 to 3 days, rapidly getting more breathless. He was being treated outside as a viral pneumonia, but oddly, he had a history of a cerebrovascular accident 4 years earlier, and since 3 years had had systolic hypertension. When he was referred to us, he was obviously in respiratory failure. He was tachycardic. His saturation was just 85% on room air, but we were able to get it up to about 94% at 4 liters of oxygen. Systemic examination just showed just a few fine end inspiratory crepitations. An initial investigation showed a neutrophilic leukocytosis, and ABG confirmed that he was in type 1 respiratory failure. That was his initial CT scan and X-ray, and you can see that a slight loss of volume and a few streaky shadows and maybe a slight haziness in the right mid-zone. So we reviewed his history, and it was very striking that he'd had a stroke at 42, hypertension when he was age 43, and he was rapidly progressing in his breathlessness, not responding to steroids and bronchodilators. His skin was pigmented, and the most important thing is his findings were all disproportionate to what we were, his breathlessness was disproportionate to the findings. So at this stage, my colleague called me in and said, look, I'm having trouble diagnosing this person. But with those previous notes, we decided that we should suspect a connective tissue disorder, sent off his autoimmune workup. His ANA immunofluorescence was 3+ positive, strongly positive, but his ANA profile was negative. And incidentally, his blood CMV PCR was also positive with 640 copies. We usually use a cutoff of about 57. Now, when the ANA is positive, the ANA immunoblot is negative, we often think of a myositis panel, something that's not covered in the ANA profile. So we sent his myositis profile. But despite antibiotics, antivirals, inhaled corticosteroids, nebulized and bronchodilators, he worsened. He became more hypoxic, and he was shifted to the MICU, and within a day needed to get intubated and was on a ventilator. And you can see the change in his CT scan. He's seeing a little more of the fibrotic shadows, linear shadows, but his infective parameters were normal. He continued to deteriorate, and he was prone. These are his chest X-rays just 15 days apart. You can see a lot more volume loss and linear opacities, suggesting that there may be some fibrosis starting. The myositis panel came back at this stage. It was anti-MDA5 antibody positive, which makes us diagnose a clinical amyopathic dermatomyositis, for short called CADM or CADM. This is one of the rapidly progressive interstitial lung diseases. There's a list of what we get in the myositis panel, but that's a clinically amyopathic dermatomyositis associated with a lot of skin features. So we went on to give him the American College of Rheumatology suggested treatment. So he has a rapidly progressive ILD. the first thing you do is it an anti-MDA5? Because that progresses really rapidly. I've seen just 3 cases, all of them died within a few months. So the recommendation, you give them IV pulsed corticosteroids, methylprednisolone, and 2 additional therapies. In this case, we chose rituximab and IVIG because we suspected he still had infection, and cyclophosphamide were aggravated, and that's what the guidelines say. So we gave him these. Unfortunately, despite all these measures, within 2 weeks of the initial presentation, the patient passed away. So as this is largely a non-pulmonology audience, I'll briefly take you through what is an ILD, what is a progressive fibrosing ILD, which we now call progressive pulmonary fibrosis, which ILDs progress rapidly, and what are our options when you have a progressive fibrosing ILD: pharmacological, non-pharmacological, surgical, and palliative. So the interstitium is this very thin sliver of tissue that is between the basement membranes of the alveolar epithelial cells and the pulmonary capillary endothelial cells. You can't see it on a CT normally unless it gets thickened by either fluid, edema fluid, for example, or tissue or fiber. And that's when you start to see it as that. Sorry, you can't see anything on this, but you can see the lines which delineate the polygons which constitute the secondary pulmonary lobule, which you normally cannot see. There are over 200 interstitial lung diseases. Some people say over 250, and that's a brief classification of them. We don't need to spend time on them. But when we talk about progressive pulmonary fibrosis, we are talking about a small group that seems to get more and more fibrotic over time. This was an expert group consensus, which I was lucky to be a part of, which came out last year in the European Respiratory Journal. So we defined it as pulmonary fibrosis that progresses despite optimal management. And we know that between a fifth and a third of patients progress within 5 years, despite this initial treatment. But rapidly progressive ILD is a different ballgame altogether. It's a descriptive form that progresses very rapidly, like our patient. Unfortunately, there's no consensus on what is the time frame to call it a rapidly progressive ILD. And we recognize that there are 4 groups really which constitute a lot of these. One is the anti-MDA5, like our patient had. Then systemic sclerosis can sometimes progress alarmingly rapidly. Acute interstitial pneumonitis is probably the worst. And we have ARDS sequelae, which may or may not be truly interstitial lung disease. So the big question is, how do we define progression? And it can be defined by and large on a CT scan, where we see a rapid deterioration, or on lung function testing, either the diffusion studies or the FVC drops by more than 10%. And studies have used anything between 6 months and 1 year to define the time period in which this drop should happen. Why do some of them undergo fibrosis? We don't know, because most people heal and they heal properly. But there's a small group who, after an inflammatory episode, progress rapidly in their fibrosis. And that's one example if you see how rapidly fibrosis has progressed from the left to the right. But not all ILDs progress. In this, you can see the bottom panel, there's been hardly any progression even after 3.5 years. On the top, however, you see rapid progression in this patient, though this is not truly rapidly progressive ILD, it's a progressive ILD. And we know there are some interstitial lung diseases that progress more rapidly than the others. The classic example is what is called idiopathic pulmonary fibrosis, but we always define it as relentlessly progressive. Many of the others progress, some to a lesser extent, some to a greater extent. Sarcoidosis, for example, accounts to a very small part of this, while connective tissue disorders can progress quite a lot. And they all progress at different rates. You can see on the left, some of them actually improve in their lung function, while some deteriorate, some very rapidly. And as you go to the right, you can see that overall, they all deteriorate, some at a faster pace, some at a slower pace. So we recognize 3 groups: the ones who we call stable ILD, which doesn't deteriorate very rapidly, the ones who progress very fast, IPF being the classic example, and many falling in between these. And if you tease out the different etiologies, you can find differences between these: chronic hypersensitive pneumonitis doing quite badly, and IPF doing the worst of all. And we recognize there are common risk factors for progression: male gender, older age, what is called a UIP pattern, typical of IPF, and those who come to us late. And in India, we find that a delay of about 15 months occurs between the first symptoms and an actual diagnosis being made. And we can shorten this time, we can probably intervene more rapidly. How do we manage these patients? We try and reduce disease progression, first of all by using antifibrotics, but also by oxygenating the patient. And there are some specialized aspects of disease management, which include pulmonary hypertension management, manage the connective tissue disorder, gastroesophageal reflux, extremely important, especially in the transplant situation, and look for sleep apnea. We know that we have antifibrotics, nintedanib and pirfenidone, which work very well, and they reduce hospitality and hospitalization and mortality. And we have a lot of new drugs in the pipeline, which have all passed the initial tests, but some have failed the initial tests. But there's a lot of new drugs that are going to be coming out. How do we treat a rapidly progressive ILD? We need to initially manage them with a pulmonologist, and then a combined management with the lung transplant team and the pulmonologist. And then finally, it goes across to the lung transplant specialist. And that's what we do. We look after them initially and then pass them on to Dr. Basha and work with him and later pass them on completely to his care. And why is ILD being talked about today? Because increasingly over time, we are having more and more patients who belong to the ILD groups across the world. It's becoming a more important part of the transplant. So I'll thank you and stop with a few key messages. Over 200 types of ILD are recognized. ILDs are being seen more often, probably because we are recognizing them better and hopefully more early. IPF always progresses, and other fibrotic ILDs may progress despite best available treatment. Some progress very rapidly, and their poor outcomes have to be predicted and recognized and treated very aggressively. And when we recognize that an ILD is of a progressive phenotype, rapidly or otherwise, we need to involve the lung transplant team early, refer to the lung transplant team. And such patients are jointly managed by the transplant team, the pulmonologist, and the palliative care teams. Thank you very much for your patient hearing.
Sir has to head, unfortunately, to another meeting. So we'll take questions right now for his talk. And then for the next speakers, we'll take questions at the end. So
So there's a wide variety of etiologies for this. Some of them are due to exposure, for example, hypersensitive pneumonitis. But even there is obviously an immune component to it. Idiopathic pulmonary fibrosis, as the name implies, we don't know what causes it. And there's another group called idiopathic NSIP, non-specific interstitial pneumonitis. Again, we don't know what is the etiology. But about 60% of patients with ILD tend to have some or the other autoimmune component. Our data shows that we have about 20% with connective tissue disorders, and another 20% approximately is hypersensitive pneumonitis. I'm going to let Dr. Basha answer that, but basically the treatment that you use for the transplant often works for the underlying autoimmune disorder also.
Sir, carcinoma of lung can also transplantation, sir. The patient is in CA lung.
So again, as I said, I'm not a transplant physician. Talks in the future, Dr. Basha will handle. But no, if they are operable, and I think Dr. Vijay will be answering that question also. If they are operable, they get operated. If not, they go on for other forms of surgery, chemo and radiotherapy.
thank you, sir, for that very comprehensive talk. Next, we'll have Dr. Ishan Kapoor. He is a consultant pulmonologist at Narayana Health. He will be talking to us about practical aspects of lung donor assessment.
Good evening, everyone. Following up and speaking after my mentor is going to be a tough task, but I'm going to try to do justice to that. So when it comes to the practical aspects of donor assessment, we need to assess the quality of the donor. So what do we need to look at? We need to look at any history of the current admission, the past medical history, the past surgical history, what led to the death of the patient, the most recent imaging, X-ray, and preferably if we can get a CT scan, the sputum cultures and the recent investigations to work up to see if the patient has any underlying infection. So what does one do when you go for the assessment? So first things first, we have to make sure that we have taken consent for donation. A lot of times we get verbal consent and sometimes the family backs out. Verification of brain death, which meets the norms as per the local legislation. There should be ABO compatibility to the recipient, serology testing, and you should carry the necessary supplies. And you should liaise with the ICU team so that any new developments have been informed to us. So what are the causes of death in the subsets of patients? The ones which we commonly encounter would be most common being road traffic accidents, trauma, any recent stroke, asphyxia, intoxication of drugs, and so on and so forth. So the causes of anoxia, like I mentioned, are diverse. And sometimes we can have patients who have hanging, drowning, status asthmaticus. But generally, the patients who have status asthmaticus or who have had hanging as the cause of death or drowning are generally not considered as good candidates for donors. So when it comes to donor criteria, the ideal criteria have been displayed there. The age less than 55 years, brain dead donors, ABO compatibility, there should be a clear serial chest X-ray, a PF ratio more than 300, and a cigarette smoking history of less than 20 pack years, and absence of chest trauma, no evidence of sepsis. Along with that, there should be no prior cardiopulmonary surgery. The sputum should not grow any bugs, and there should be absence of purulent secretions on bronch, and ideally no obvious anatomical abnormality. But sadly, we don't live in an ideal world, so we have to look at certain candidates who are in the gray zone and also extended criteria when it comes to donors. So when it comes to extended criteria, we have some leeway and we accept donors who are in the age group of 55 to 75, even donors who are donating after circulatory death, and donors whose PF ratio is less than 300 and who may have a higher smoking history, more than 20 pack years. And some of them may even grow some amount of, may grow some organisms, and they may have some purulent secretions on bronch, but we should, while doing the bronch, we should also assess that these secretions clear off and that there's no repooling. So why do we need to be physically present and assess the donors in detail? Because we need to avoid early post-transplant complications, the most dreaded one being primary graft dysfunction. And this is the one which is linked to a longer ICU stay. And almost a third of the deaths that happen within the first month are because of this. And this is linked to the donor's smoking history, the mode of lung preservation, sometimes a longer ischemia time, and if there's pulmonary hypertension in the recipient. If your candidate, if the donor has had prolonged ventilation more than a week, tracheostomy, these can be red flags, but they're not absolute contraindications. Donors who have atelectasis and plugs can also have some suboptimal gas exchange. And generally, we do a bedside bronch to assess the donors to differentiate atelectasis and pneumonia. So pneumonia or severe atelectasis will generally result in shunting of the blood, and we get a suboptimal PF ratio. Like I mentioned before, ideally we are looking at a PF ratio of at least above 300. And in morbidly obese patients, what we commonly encounter are basal atelectasis, and majority of the times in these subset of patients, when you open the chest and provide Valsartan, the atelectasis slowly resolves and there's an improvement in PF ratio. So infection. So if you know for a fact that the donor is growing a bug, a Staph aureus, or any other multi-drug resistant bacteria, then we generally don't accept the donor lungs. However, if there's any absence of radiological evidence of any infection and bronchial cultures are positive, they generally don't have any significant impact on the 1-month mortality. And positive blood cultures alone should not be considered as an absolute contraindication to transplantation. So you should take the overall clinical picture of the donor while assessing. You have to assess the ventilator parameters, you have to see the donor lung compliance, and we look at the plateau pressures and the peak airway pressures. So if the peak airway pressure overshoots 25 or the plateau overshoots 20, there may be some lung edema or obstruction. If any history of malignancy should raise an alarm, and we should liaise with the medical oncologist when it comes to making a decision with regards to these patients. And only localized and excised skin, commonly basal cell carcinoma, and primary central nervous system malignancies may be suitable for donation. And we also have to bear in mind that these patients may be on a whole spectrum of drugs. Some of them may cause lung fibrosis, and which can add on to the overall picture. Now, COVID is something we also, when we go there, we generally see and ensure that we at least have a negative testing for when it comes to the donor. And if the donor has had COVID in the past, we can still accept these organs. If there's a recent COVID infection which is resolved, and we have got a negative nucleic acid amplification test, or a positive one, which is dating 21 to 90 days after the date of onset, they are not likely to transmit the infection. So we can proceed with these organs when it comes to assessment. Now, if the donor has asthma, like I mentioned before, status asthmaticus, we generally don't accept these organs because they have hypercarbia and elevated PA pressures. Well-controlled asthmatics who have been on regular inhaled therapy are generally, we can accept them, again, bearing the risk-benefit ratio. And the ones who've had a history of bronchial asthma and who are partially controlled, such donors are usually classified as moderate risk. So again, we have to take our decision based on the urgency as well. So waitlist mortality is highest in the pulmonary fibrosis group, and with a rapid decline in the respiratory status, pulmonary fibrosis patients, they demonstrate lesser pre-op physical endurance, and they are sicker as compared to the COPD subset of population. And so some of the centers are relaxing the donor selection criteria when it comes to pulmonary fibrosis subsets because of the criticality of their underlying condition. So I've mentioned that, like we don't live in an ideal world. We will not always get an ideal donor. What are the extended, when it comes to the extended donor criteria, these extended donor criteria, like I've shown in the table before, they've been associated with a higher primary graft dysfunction, but we have to bear in mind that there was no impact on the acute rejection, chronic rejection, and ultimately the long-term survival. So in the right group of patients, they can be definitely considered. When it comes to the surgical aspects and the aspects of size matching, surgical feasibility is quite important. We should make sure that there's appropriately size-matched lungs have been used. There should be no major discrepancies in the bronchus, pulmonary artery, pulmonary vein sizes, because a larger discrepancy will make the bronchial anastomosis challenging, and there'll be a greater chance of stenosis or dehiscence. Now, if you have two small lungs, and if you don't, there's a size mismatch. Two small lungs in a large cavity can lead to pneumothorax, hemothorax, and other bleeding, increase the risk of bleeding. Whereas large lungs in a smaller chest cavity will increase the risk of open chest and surgical wound complications. Now, the respiratory mechanics, we know that the chest wall conforms around the lung parenchyma in chronic diseases and in idiopathic pulmonary fibrosis. And in idiopathic pulmonary fibrosis, as the name suggests, fibrosis, the chest cavity becomes shrunken. And the diaphragm moves up and down, and the rib spaces are crowded. And the total lung capacity reduces as time goes on. Whereas in COPD patients, the chest cavity is large, diaphragm remains flat, and both these diseases create inefficient respiratory mechanics, and it's important that there is no size mismatch. And the lungs that cannot be, what happens when we, after donor transplant, the lungs cannot be seen separately, and seen separately from the cardiovascular system, as both pulmonary overflow and underflow situations could affect the long-term lung function. And ideal world, the donor and recipient body surface area should match closely. But in cases of severe pulmonary hypertension, the cardiac output increases post-transplant, and a sudden increase in the flow is considered as a risk factors for the higher graft dysfunction. And a larger vascular bed and a larger volume would minimize the global and regional pulmonary overdistension. So how do we avoid the size mismatch? There's a formula called the predicted total lung capacity that we use. The values for men and women, that's the formula that's been displayed there. This is what we use. Along with this, in our setup, we take into account the height of the donor and the height of the recipient as well. And in our MDT meets, we also take into account the AP diameters and the transverse diameters of the chest and the chest cavities, and so that there's no size mismatch. But the problem with the predicted total lung capacity is that it does not take into account the weight, the race, and the cause of the recipient's lung disease. So there's a new technique which is more precise called CT volumetry, which can be utilized. And I'll be concluding in the next 2 or 3 slides. To primary pulmonary hypertension, it may not affect the chest wall size, and oversized donors in this subset are associated with a better survival. Whereas in fibrosis patients, oversized, we generally avoid oversized bilateral lungs for the transplant because they could result in difficult chest closure. And in COPD patients, implanting a larger lung allograft may not result in the normalization of the respiratory mechanics and may have a negative impact. So this is an image. These are images showing a pre-op chest X-ray of a 67-year-old tall male COPD patient A. B is post-op after he's received the transplant from the donor. And in the second, in the B diagram, you can clearly see that the chest cavity and mechanics is still well preserved. And in the C, which is a tall female COPD patient, this patient again received a tall female donor. The lung hyperinflation persisted even after transplantation. This is because of the significant oversizing of the donor lungs. So what is my take-home message? That out of all the solid organ transplants, one has to definitely keep in mind that lung transplant has its is probably the most challenging. And with the invent of new therapies and interventions for various lung diseases and the rising population of advanced age, we need to necessitate the implementation of various strategies to screen and utilize the donor lungs. And we have to broaden our horizon and broaden the spectrum, and also seriously consider using extended donor lungs depending on the clinical scenario and the urgency of the recipient. Thank you so much.
Thank you, Dr. Ishan. Next, we have Dr. Vijay CL. He is a consultant thoracic surgeon at Narayana Health, and Dr. Vijay will be talking to us about basics of lung transplant surgery.
Thank you, Dr. Aditi, for the introduction, and I welcome all the delegates for this wonderful event. I'll briefly go through the basic aspects of lung transplant surgery in next few slides. We have already heard about what is the lung transplant surgery and when it is done and from whom we harvest the donor lung for the transplant. Briefly, I'll try to go through the how aspect of the lung transplant surgery in few slides. Options of lung transplant surgery include single lung transplant or a bilateral lung transplant, and option of combined heart and lung transplant as well. But nowadays, most commonly, the bilateral lung transplant is done as it is proven to have a better long-term survival compared to unilateral lung transplant. Coming to approaches for lung transplant surgery, typically in single lung transplant, you can go for either an anterolateral thoracotomy or a posterolateral thoracotomy. For a bilateral lung transplant, the commonly used incision is either clamshell or bilateral anterolateral thoracotomies. For a combined heart and lung transplant, either a midline sternotomy or a clamshell thoracotomy is used. Coming to brief anesthetic considerations, obviously patient will need a lot of monitoring lines for monitoring arterial line, central line, and even PA catheter, transesophageal echo for monitoring of the cardiac function, DFIPS. From surgery point of view, epidural catheter for pain relief in the post-op, which probably helps them to breathe better, and double lumen tube or ET blocker for isolation of the lung. Typically, the lung transplant is done under either an ECMO backup or a cardiopulmonary bypass. CBB is necessary in heart and lung transplant, obviously, and in few selected patients, it's more beneficial, particularly in severe pulmonary hypertension patients, patients with cystic fibrosis where they will have a lot of secretions which preclude single lung ventilation and lung isolation. And in pediatric age group where a double lumen tube insertion and single lung ventilation might not be feasible in them. Basically, in any patients with hemodynamic instability or acidosis or hypoxia indicates the need for cardiopulmonary bypass. After the donor lung recruitment, the next important step in doing a transplant is a recipient pneumonectomy. We have to be careful about a few important things. Commonly, the major issue is bleeding, since the patient will go on either bypass or on ECMO and with heparinization. So we have to take care during the mobilization of the recipient lung itself to avoid bleeding in the post-op settings. To preserve few important nerves in the chest, which might have implications in post-operative phase, including phrenic nerve, which can lead to diaphragmatic palsy and issues with weaning ventilation in the post-op setting. Recurrent laryngeal nerve can lead to injury, can lead to hoarseness of voice and aspirations in the post-op setting. Diaphragm, many times, especially with pulmonary fibrosis, the diaphragm would have moved up. While entering the chest, we might even injure the diaphragm. And more important, the recipient bronchus. To avoid, importantly, the devascularization, which can have post-op implications with anastomotic complications. Typically, commonly done under commercial approach through the fourth intercostal spaces. And commonly, the more diseased lung is transplanted first and followed by the contralateral lung. In our setting, as we have seen in the previous slides, majority of the patients are pulmonary fibrosis, and many of, especially our Indian setting patients, can have a lot of pre-existing infections and commonly tuberculosis, either treated or untreated. Will have a lot of adhesions and can take a lot of time to mobilize the lung itself. We typically loop all the hilar structures before the arrival of the donor lung so that we can reduce the time for the implantation of the donor lung. This picture shows the looping of the mediastinal structures, including the pulmonary artery and the vein and the bronchus before the donor lung arrives. And the bronchus is typically divided with staplers to avoid spillage of secretions and contents which can infect the pleural cavity. This is how at the end of the procedure looks like. The hilum, all the mediastinal structures are divided and the pleural cavity is packed with either cold saline mops or packs for the donor lung. This is how a recipient lung will look like after the pneumonectomy on both the sides. A diseased lung, which are fibrotic, hard, and almost like liver in consistency. In contrast, this is how a donor lung will look like, which are pink in color and nicely inflated compared to the bad recipient lung. And when we get the donor lung, we have to do the separation because they are all harvested en bloc, sometimes with heart or with or only the lungs. So we have to divide the structures in the middle to separate both the right and left lungs. The picture shows division of the atrium and the pulmonary artery to separate the right and left lung. And this picture shows the division of the bronchus on the left side to separate the lungs blocks. And once the things are prepared, we cut open the bronchus and prepare the lung for implantation. So implantation, the bronchus is cut, leaving as short the donor bronchus as possible, as it's already a devascularized bronchus. to avoid ischemic complications in the post-op. And the donor bronchus secretions are sent for cultures and sensitivity. And the bronchial anastomosis is done first, followed by the pulmonary artery and the atrial anastomosis. This picture shows the implantation of the donor bronchus. The membranous wall is run in a continuous fashion, followed by the anterior wall, which is run in interrupted fashion. As Dr. Ishan has mentioned, many times we might face size discrepancies between the donor and the recipient lungs. So we might have to adjust with placing the sutures appropriately, or sometimes if necessary, telescoping the smaller bronchus into the bigger bronchus. Followed by the pulmonary artery is anastomosed, typically in a continuous fashion using 50 or 60 prolines. And the last anastomosis to be done is the left atrial anastomosis. After the completion of all the anastomosis, implanted lung is ventilated gently with the FiO2 of 50%, making sure that not to expose the implanted lung to higher FiO2. And the PA clamp is released slowly to allow for controlled reperfusion of the implanted lung. And finally, the lung is de-aired through the atrial suture line. The contralateral lung is implanted following the similar principles. This is a final picture showing implantation of both the lungs, giving a new breath of life to the patient. I would like to end my talk with this quote by Bart Millard. As long as there is breath in our lungs, our story is still being written. And I welcome all, and let's get together to help patients who are out of their breaths to continue to write their stories. Thank you.
Thank you, sir, for that beautiful and eloquent talk. Next, we have Dr. Bharsha Khan. He's a senior consultant and the director of lung transplant at Narayana Health City, Bangalore. Sir will be talking to us about post-operative care in lung transplant patients.
Good evening, warm welcome to all of you. First thing, lung transplant is still in infancy as compared to other solid organ transplant. And there are giants sitting in this room from liver and kidney. But I'll share an analogy from financial market. Any big cap company was smaller cap couple of years ago. So with this, I think that our lung transplant numbers will also going to improve in near future. This is the lung transplant median survival outcome from ISHLT. It varies according to different diseases. The four major categories of diseases are COPD, ILD, pulmonary hypertension, and bronchiectasis. When I started the practice in transplant field in 2010, around 50% of cases were used to be due to ILD and rest, PAH, CF and all. However, now the scenario is changing and now 90% of the cases across the world are done for ILD. And as you can see that the median survival is 6.5 to 7%. 1 year mortality is significantly high. Around 80% people survive with mortality of 20%. And there are certain reasons why lung transplant outcomes are not suboptimal as compared to other. First, it is a disease donor program. We don't have luxury of having a matched living related, and sometimes we get extended donors. The second thing which contributes to this is ischemia time of the lung. You have to do the surgery from retrieval to implantation within 6 to 8 hours. Third thing is this is the only organ which is exposed to outer environment, so more risk of infection. The number fourth is lung is the organ which is full of lymphocytes, so more chances of rejection. And last but not least, to add another insult is when we do anastomosis, the new recipient lung is devoid of bronchial arteries. It takes 6 weeks for normally person to develop those bronchial arteries. So there is a lot of ischemia and slough at the anastomosis site, and this is a perfect environment to have an infection. So keep all these things leads to little bit suboptimal outcomes. Under the vision and of our chairman, Dr. Shetty, we feel proud to share with you that at least in Karnataka, we did first successful lung transplant as well as first successful heart transplant. The gentleman on the left side, he did first bilateral sequential lung transplant in 2018 for bronchiectasis, and the gentleman on right is a heart lung transplant. He's the oldest surviving patient in the country with heart lung. Now he has reached 73 with no hospitalization. The gentleman on the right side had a good post-operative outcome. However, he succumbed to his illness due to massive bleed from his tracheostomy, probably tracheoinnominate fistula. So we get referral, so as I said, predominantly it is interstitial lung disease, 90%, while CF, bronchiectasis, COPD, group 1 PH, lesser and lesser referral because there is significant improvement with the availability of medications for PAH. We have better treatment options for CF. So these patients are living longer with better quality of life. So that's why the transplant numbers are coming down for these things. And predominantly it is interstitial lung disease. So when we get referral for interstitial lung disease, it's a heterogeneous group. Dr. Murli Mohan sir has already shown us it's around 250 diseases which is put in one group. It is equivalent to having a cirrhosis, but there are different etiologies. And it matters a lot to understand when we get a referral because some of these patients have connective tissue disease. They are heavily immunosuppressed. Some of them are getting MMF, rituximab, all those things lead to significant immunosuppression and it affects the post-transplant outcome. And then there are some specific therapies for interstitial lung disease, like we know that antifibrotics, all these leads to delay in wound healing. For one subgroup LAM, we are using sirolimus also pre-transplant, and it significantly impairs the, again, wound healing. Many of these patients, especially in connective tissue, are going to receive rituximab and IVIG, and it is going to have an effect on cross match. So as an astute transplant physician as well as primary care physician, we should understand these technical challenges when we get a referral for ILD. So this year we have done 5 transplant, 1 heart lung and 4 lung. The heart lung transplant was for ASD, and out of these all 5, we have 1 mortality. Rest 4 people got discharged. They are doing extremely quite well. And to tell you, all these 4 patients were extremely sick. They were in hospital on high flow oxygen. They could barely move around the room. So these patients of lung have worse quality of life as compared to other organ. A patient who is waiting for kidney transplant still comes in out of the hospital for dialysis. These patients wait inside the hospital for months and years. The gentleman, 40-year-old gentleman, is the first international patient who got transplant because of the effort of Dr. Rajni. He waited for 2 years, and his weight by the time he got transplant was 30 kg. And the girl on the top for heart lung from Lucknow waited for more than a year to get an organ. So these are the challenges, and we have a significant high waitlist mortality because it becomes too difficult to get a diseased organ. Some basic things, immunosuppressive medications. So there is a terminology because I see a lot of patients, primary care physician, either pulmonologist or medicine, some basic terms. Where one is induction therapy. Induction therapy is In the initial post-op period, we give heavy immunosuppression, especially targeting the T cell therapy. Then second is the maintenance immunosuppression. And whenever there is a rejection, we again hike up the immunosuppressive therapy. While coming to maintenance immunosuppression, we are not as lucky as liver team. They remain lifelong on triple immunosuppression. Historically, when the transplant program started with the advent discovery of cyclosporin and azathioprine, that is the time that transplant program success start to happen. And many traditional programs, including where I got trained, Toronto, they still use cyclosporin and Imuran if patient is not having HLA antibodies. But most of the centers are now moving from these to tacrolimus and MMF, and they remain lifelong on steroid. And then we target the, maintain the level of the CNI. Initial first year, we try to keep above 10 and between 10 to 15, while after that, between 8 to 10. One important challenge which all of us face, whether it is lung, kidney and all, we have a patient who had got transplant and he lands in ICU and he's having sepsis. So there are 3-4 questions immediately comes from the ICU team. Now he's having sepsis. What shall I do with the immunosuppression? Second thing which is common, this patient is having renal injury. He requires dialysis. What shall I do with the immunosuppression? Another common question which get asked is, he is not able to absorb the medication. What are our options? So coming to the first question, patient is having sepsis. What shall we do our immunosuppression? We have to look at the immunological profile of the patient. If it is really high risk profile, then probably I'm going to cut down on my immunosuppression instead of just stopping everything. While if there is low risk and significant sepsis, it is worth considering holding on MMF for at least 1 or 2 weeks. Now coming to second scenario, not able to absorb the medicines, then we can use either IV cyclosporin. We don't have tacrolimus IV, but we have IV cyclosporin and it is 1/3 of the dose what we use for oral. Or the last option, which is I'm quite comfortable, is using sublingual tacrolimus. You have to use half the dose. So these are the options which we can use. And the last thing, all these medicines are metabolized through liver metabolism. So there's no effect on when they are on dialysis. Prophylaxis wise, we keep them on triple prophylaxis, CMV prophylaxis for 3 to 6 months, lifelong Septra prophylaxis. The most controversial is antifungal prophylaxis. Some people, there's a universal targeted therapy or preemptively. But you have to make your antifungal protocol based on local infection in your ICU and what is happening at the anastomosis. And we use nebulized amphotericin to azoles, depending upon the risk profile of the donor recipient lung. We want primary care physicians to be involved. They are play a crucial role when they get involved before transplant as well as post-transplant when the patient goes to his home. So when pre-transplant, we want them to refer the patient in a timely manner. Please make sure the patient is enrolled in a rehab program, take care of their vaccination, nutrition, avoid unnecessary use of blood products to prevent HLA sensitization. And in the post-transplant period, we again want them to follow the patients after 1 year closely and look for any new organ dysfunction and all. This is the current scenario for transplant in India. We have only a couple of centers across. So Medanta just started. Then Gujarat, we have Maharashtra. So predominantly these 3 places, Bangalore, Chennai and all. And patients are predominantly coming from the this part of the world. So it is important that we give education to physicians, internists, pulmonologists to how to manage these patients once they reach the native place. And the communication is key. Whenever they have something, either they have a high-grade fever, pneumonia, worsening kidney injury, drop in graft function, they should communicate with the primary team. I'm going to skip. And we also want these patients to live safely. And once they reach in community, there are certain instances where catastrophes happen. Patient went to swimming and then he developed Naegleria infection. So avoid using well water, proper hand hygiene. You have to be prudent when you are not to consume raw food and pet ownership. So these things are minor issues, but it can have long-term issues. Uh, Cat related, I forget the name, it causes a significant infection. No, not toxoplasma, there's another one. So these things are important, and it's a team sport, and so many players play a role for a successful outcome, from transplant surgeon to gastroenterologist, cardiologist, coordinator, dietitian. So it's a team sport. I would like to end that there's a huge burden of the disease, and there is a difference of protocol across all centers. And one patient who is considered high risk can be accepted at other center depending upon the experience of the team. And we need to have a robust system to understand the risk factors which can affect the long-term outcome of the patient. And these are some of the patients who underwent successful lung transplant, and they are doing quite well. And these are their statements. Thank you very much.
I'd like to invite the other speakers, Dr. Vijay and Dr. Ishan Kapoor, please, for questions.
Hi, I'm Dr. Zamir. Loved your talks. Very, even though we do kidney transplants, we see liver transplants, we see a lot of patients across. Generally, forgive my ignorance, but we don't hear about, we hear patients with renal failure, we hear patients with liver failure. We don't kind of hear in the general common public about people with lung failure or interstitial lung disease and things like that. So is there a big number of patients who actually require this as compared to liver, kidney failure patients? And is it routinely, or do you often see that these patients are not diagnosed as or not regarded as patients who require lung transplant, and you get very late referral? And does it affect the impact or the overall outcome?
So there's a huge burden of the disease, and I think they need, in terms of number of transplant, probably much more people need as compared to kidney and liver. But the message is not correct. It's not going to the community in a right way. People are too hesitant, and one of the challenges is that it is not established even in AIMS or PGI. So while kidney and liver is well established, the CMC started in 1980. When I was in Apollo in 2006, that was my motto when I used to see kidney and liver team, that why we don't have a transplant program in our country. And one of the reasons I moved out. And so it's just more awareness is getting created, and they have the worst quality of life, no doubt, and they just confined to home. It is just not so much appreciated.
Thank you.
Lot of post-COVID, the lungs have been suffering. You had any experience in transplanting the post-COVID lungs?
So they had, but COVID patients behave like ARDS, and in ARDS also around 40 to 60% will recover. So initially, when COVID struck, no one knew the natural trajectory of the disease. We have followed we are the one of the biggest at that COVID time centers in the country. We were not doing ECMO, but we run at one time more than 1,200 COVID beds. And we noticed that they were quite sick, but the way it was described that it is going to a epidemic of lung fibrosis, it is not like that. Many patients gradually over a period of 6 months and all, their lung has recovered. And it is important to understand the natural history. So there were initial euphoria about transplant, but later on people realized that if we support these organs, many of these patients would just recover slowly. And it is just like an ARDS. It takes time, but it recovers. But there are some selective group of patients who will need. But in COVID pandemic, because it's pandemic, it requires a lot of resources. So it was our center policy not to offer anyone ECMO and transplant, because at that time we were running a 1,200 beds only for COVID. So that was a just difference in goals of care.
Excellent talk, sir. My question is related to HLA. I'm from HLA background. So, sir, how do you deal with the patient who are sensitized to HLA antibodies? This antibody removal remains the same like kidney, or it's different? And second question related to, do you see antibody-mediated rejection post-transplant in lung transplant cases?
Yeah, so excellent question and difficult also. Probably you must remember we had a patient who was waiting for heart and lung transplant, connective tissue disease, and she was having antibodies, and 2 times the cross match was positive. The challenge is we cannot do a plan because after some time there will be rebound. So in some selected cases, when you are doing a high volume, you can do those things. Same thing what kidney does. You do plasmapheresis, you do rituximab, IVIG, and Western data has shown that the long-term outcome is also similar. The challenge in our country is most of our donors are having MDR bacteria in their lungs, and when with these immunosuppressions, things can lead to have catastrophe. And the second thing is the cost. Any AMR treatment, immediately your cost will lead to 5 lakhs and something above that. So we have a discussion with couple of patients who are want to proceed for that. So it's a shared decision making. So it is doable in specific groups of patients. So if someone has PAH who is not infective, I would be keen to get rid of these antibodies. But if someone has COPD, infective or bronchiectasis, it is not worth spending so much time to do these things.
Bronchial artery takes 2 weeks to you have to do any CT angio to see they opened up and
no. So it's an end. You have to wait and watch, and we have to see by doing serial bronchoscopy the vascularity of anastomosis. So if your anastomosis vascularity is good, that means bronchial arteries are there. But if vascular anastomosis is showing a lot of necrosis and slough every second, third day, you have to do bronchoscopy. You have to, that is an indirect way. Taking them to CT scan again requires a lot of effort and all. And even if we difficult to see these are too small. And second thing is, even if we see what intervention I'm going to do, because it has to heal naturally. So the key is when you are doing anastomosis, probably he can elaborate not to disturb that area around the bronchus and be gentle. This is a physician word. Probably he can tell you how to avoid those challenges.
Even the post anastomosis of the donor lung, it's not like that the bronchial arteries will reform by themselves. It's the collaterals. It's difficult to visualize even on the scan also. And as Dr. Basha said, that can be assessed indirectly through bronchoscopy rather than doing just CT for assessing the bronchial anastomosis. Even though people have tried doing microvascular anastomosis of the bronchial vessels from the donor to the recipient, but they are even smaller than coronary vessels. The revascularization and the patency is not of that great extent. So people have given up doing bronchial artery anastomosis. So we rely on preserving the vascular supply of the recipient bronchus and avoid denuding and devascularization of the donor bronchus as much as possible, and depend on collateral formation from the recipient tissues surrounding the bronchus.
Thank you for that very engaging discussion. In the interest of time, I think we'll move on. If anybody has any further questions, the speakers will still be available and they can meet them personally.
Thank you very much.
I'd like to call Dr. Babira to give a token of thanks to all our speakers. Dr. Ishan Kapoor. Dr. Vijay. And Dr. Basha Khan. With this, we'll move to the last session, which is on heart. And thank you to everyone in the audience for still sticking out till the end. I know we are running behind time. We'll try to wrap up quickly, but hopefully this has been an engaging event for everyone. So, my name is Dr. Aditi. I'm a heart failure and transplant cardiologist at Narayana Health. So I'll be talking about when is heart transplant needed. So I thought we'll start off with a couple of cases to highlight the point of when heart transplant is necessary, which patients to be considerate in. And like patients with cirrhosis or renal disease, again, heart failure can happen from multiple different etiologies, but the end result of this will be end-stage heart failure. So the first case is a 40-year-old male smoker with no prior medical history. He presented with an anterior ST elevation MI and underwent primary PCI. He develops VT and cardiogenic shock. So he had a balloon pump placed, but remained on high doses of pressors. And then he was placed on ECMO with a balloon pump. This is his echo showing anterior and septal regional wall motion abnormality with a severely reduced ejection fraction. So he was on ECMO for 1 week. His blood pressure remained in the 90s. He was also on dobutamine. And as we do in patients with ECMO, we want to see if we can wean them off, stabilize them on medical therapy, or whether they'll require some form of durable support. So with weaning his ECMO flow, his echo still showed severely reduced EF. RV function was mildly reduced. Hemodynamics are very important to assess really how the cardiac function is, how the pulmonary pressures are. And with weaning ECMO flow, his hemodynamics were pretty good. So his right heart as well as wedge pressure was low, which is a good sign. So we were able to successfully wean him off of ECMO. His blood pressure remained in the 90s. His end organ function normalized. He was started on low doses of heart failure medications, and he continued to require diuretics. He was discharged on low doses of heart failure medications. And over the next 6 months as an outpatient, he was switched to an ARNI, started on beta blocker as well. You can see over the next 6 months, all of his heart failure medications were up titrated to the maximum doses, which is a good sign. And he had a primary prevention ICD also placed. He was NYHA function class 1, and this is his echo. So his EF is still severely reduced. You can see some remodeling has happened. The LV is dilated now. There is a wall motion abnormality as well. However, the patient is doing really well. And with further exercise testing as well, we see that his oxygen, that his peak VO2 and VEVCO2, which are markers of cardiac output and the oxygen utilization of the heart, are both very good. So he has severely reduced EF, but is doing well on medical therapy. So clearly he has a very good prognosis based on all the information that we have so far. And this patient does not require a heart transplant, even though he has a severely reduced ejection fraction. So who are the patients who will benefit from heart transplant? Our next case is a 45-year-old female who has a severely reduced ejection fraction due to non-ischemic cardiomyopathy for many years. She's on low doses of heart failure medications, remains quite limited, has a CRT, but no improvement after that. Started on low dose of ARNI as well. This is her echo, which is showing severe biventricular dysfunction. You can see there is advanced remodeling with walls that are thin, biatrial enlargement as well, and MR and TR. Over the last 2-3 years, she has further worsening. She has recurrent ventricular tachycardia, increasing doses of diuretics. Her creatinine starts rising, her blood pressure is low, and her medications have to be stopped. So we did a right heart cath to further stratify her, and she has elevated pulmonary pressures, elevated wedge pressure, and a low cardiac index. Her exercise test also showed that she is very limited. So her peak VO2 was low at 10, and her BEV-CO2 was also elevated. So she was evaluated for heart transplantation. After a waitlist period of 2 months, she underwent heart transplantation, and the surgery was successful. And post-operatively, she was discharged. This is her prior to discharge. This is her echo after transplantation. Sorry, it's not playing, which is showing normal function in contrast to her echo before. And now it's been 1.5 years since her transplant, and she continues to do well. This is a third case, 22-year-old male with 6 months of dyspnea. His cath interestingly showed a mid-LAD lesion. He had a large infarct on his MRI, interestingly. He was admitted with decompensated heart failure, required inotropes, then admitted 1 month later again with decompensated heart failure, anasarca, hypotension, acute kidney injury, and congestive hepatopathy again. His right heart catheterization showed elevated right-sided as well as left-sided filling pressures with pulmonary hypertension and a high PVR. He was started on inotropes, and cath was repeated, still showed elevated PA pressures and low cardiac index. So we placed a balloon pump, which helped to bring down his PA pressures. Then he was listed for heart transplantation, and 2 weeks later, he underwent heart transplantation successfully. So keeping these cases in mind, when should a patient with heart failure be referred for heart transplantation? So typically, this is the staging classification that we use. ACC stages A, B, C, and D. And we know stage D patients are those with end-stage heart failure. But even those who are stage D have a broad range in terms of how functional or not they are. Typically, they will be functionally limited, so either function class 3 or 4. But even within that, there is a big spectrum. So we use the Intermax profile to further classify how limited or not these patients are. So patients who are Intermax profile 7 are somewhat limited, but they can still sort of do their activities of daily living. They're housebound, but not getting hospitalized really. And then stage 3 and 4 patients who are getting hospitalized again and again. And Intermax profile 1 are patients who are in critical cardiogenic shock. So the patients who are in this profile, Intermax profile 2, 3, 4, 5, these are the ones that we want to consider for heart transplantation. Intermax profile 1 patients can also be considered, but typically they have a high mortality and don't do as well post-transplant. So this is just to highlight patients who are inotrope dependent heart failure have a very poor survival. Their survival is just 10% at 1 to 2 years. So clearly they will have a survival advantage if they undergo heart transplantation. Even patients who are not on inotropes but are Intermax profile 4, 5, 6, and 7 also have a not so good prognosis. So Intermax profile 4 patients have a 40% survival at 1 year and 80% for patients who are Intermax 6 and 7. So Intermax 6 and 7 patients also need to be closely followed. Exercise testing is a very useful tool to stratify patients who have advanced heart failure. It is reproducible and provides information about their cardiovascular reserve and has been shown to have prognostic value. So there is a benefit from transplanting patients once their oxygen consumption is less than 12 ml per kilogram per minute if they are on beta blockers and less than 14 if they're not on beta blockers. And in women and patients who are less than 50 years of age, a peak VO2 of less than 50% of predicted can also be used, as well as a VEV-CO2 slope, that is a ventilation equivalent of carbon dioxide slope of greater than 35. These are poor prognostic signs, and these patients should be referred for heart transplant. If we don't have CPET, then even a 6-minute walk test can be used, less than 300 meters, or a drop in blood pressure with exercise, or a recovery heart rate response of less than 12 beats per minute. These are poor prognostic signs, and these patients should be considered for heart transplant. There are several risk scores also which can be used. The couple of ones that have been shown to have prognostic value in advanced heart failure patients are the heart failure survival score, Seattle heart failure model, and MAGIC score. These are all available online. These calculators are available online. You can plug in the requirements. They're a combination of clinical parameters, and they can tell you what the patient's 1-year survival is going to be. So if the 1-year survival is 50% or less, those patients should be considered for heart transplant. So to summarize, what are the triggers for referral for heart transplant? It is not just ejection fraction, it is a combination of various clinical parameters. So clinical features like more than one heart failure hospitalization, NYHA class 3 or 4, intolerance to goal-directed medical therapy, increasing diuretic requirement, low blood pressure, poor exercise capacity, CRT non-responder, or cachexia. Lab values like impaired organ functions, so elevated renal function or liver function, imaging parameters like a severely reduced ejection fraction, large area of aneurysm, moderate to severe MR or TR, high PA pressures, or low flow low gradient aortic stenosis, and then risk scores like MAGIC score and Seattle heart failure model. All of these should be used in combination to see when a patient should be referred for transplant. You don't need to have all of these parameters, but even if you have one or two, you should definitely think of referring these patients. And this is a nice mnemonic to remember. I need help. These are markers of advanced heart failure. I for inotrope requirement, N for NYHA class 3 or 4 and worsening natriuretic peptides, E for end organ dysfunction, E for very low EF less than 20%, D for defibrillator shocks, H for hospitalizations, E for edema and escalating diuretic use, L for low blood pressure, and P for prognostic medication. So you're having to decrease their heart failure medication so you're not able to start them. So to conclude, when do you refer for heart transplantation? If you think the patient has a more than 50% chance of dying in the next 1 year, you should refer them for heart transplant. So ask yourself, would you be surprised if the patient died in the next 1 year? If your answer is no, then heart transplantation is the right treatment for the patient. Thank you so much. So our next speaker will be Dr. Shashiraj, and he will talk about indications for pediatric heart transplant.
Good evening, everyone. Thanks for coming in and thanks for who have joined online. Now, I'll just try to give a little bird's eye view of what Dr. Aditi has already given the granular details of, end stage heart failure and when to refer. Now, let's see what is heart failure. My topics will be, how do we recognize advanced heart failure and what would be the, treatment strategies and their outcome. As we know, heart failure is essentially a pathophysiological syndrome which results from ventricular dysfunction, either from volume or pressure overload, alone or in combination. In other words, inadequate cardiac output to meet tissue oxygenation and or energy demands. So this was way back in 1980 by Brownwald. Now, the societies say term to use heart failure instead of congestive heart failure, which was like about 20 years ago. Now things are, changing around. The field of heart failure has not changed, but the approach and the mindset probably is changing, every decade. So we just have a, updated definition worldwide just 2 years ago, right? Universal definition of heart failure. So nothing magical about this, but just the application of what we already know. And this was just defined in 21. So, right? So symptoms and signs of, heart failure in combination with an elevated BNP or congestion. So this would be a very, simplistic way of looking at a definition of heart failure. Now, how does it help to help the patient is appropriate use of terminology and communication to the patient is what, makes them adhere to the medicine and follow up, which is ultimately what we want them to benefit from. Yeah. So. Now, there are different, cutoffs and based on age and, obesity, no obesity and all those, but we are all familiar with these. So hemodeterminants of, natriuretic peptides, these are all sort of basics. The NT-proBNP or BNP can be elevated both from, pressure or volume overload, from systolic dysfunction, diastolic dysfunction, valvular dysfunction, as well as, right and left heart dysfunction. It helps with diagnosis because now we have in the definition, and severity, which helps in prognosis. Of course, it doesn't tell much about the etiology, but it's a very simplistic way of assessing heart failure, and it's now quite widely used, even in small towns. Yeah. We wrote a series of review articles way back 15 years ago on BNP and NT-proBNP. We didn't realize that it would be really one of the key message to a general healthcare provider about what is the value of this, although the physiologic principles of this has been known for decades. Again, going through different age groups, we have different cutoffs, but more so the trend of the test in a particular patient is what really helps as one of the marker for disease severity. Of course, with the use of ARNI, we use less of the BNP. So for a non-cardiology audience, I would say that when you look at a lab test, how we order and how the nurse reports it is what really matters. There are 3 different tests. In fact, in India, the pro-BNP is really not available, but the BNPs used to be available. But now with the use of ARNI, probably we are getting away from using BNP as a lab test. Yeah, because it is not really valid in patients we use ARNI. So by default, if we just follow what test is used and what is the cutoff would be helpful. Now, this is another simplistic way of just diagnostic algorithm for heart failure. When we see a typical patient with signs and symptoms of congestion, low cardiac output, X-ray, ECG, and an NT-proBNP, then we could we get a phenotypic presentation of where this patient would present, whether patient with low ejection fraction, with preserved ejection fraction, but diastolic dysfunction or a valvular heart disease, or a biventricular dysfunction patient. Now, again, these are different terminologies. Acute heart failure would be someone, classic prototype would be a myocarditis, presents in hours to days. Chronic heart failure, the terminology has impact on long-term outcome. A patient presents, a 20-year-old healthy patient comes with myocarditis, low EF, on mechanical support and inotropes. He has a, presumably a good prognosis, but he still has a, future risk of having dysfunction and whatnot. So we are getting into a phase of more understanding of molecular basis of even a septic cardiomyopathy, for example. We did a study about 15 years ago on just septic shock and septic cardiomyopathy. Now, 10 years down the road, we will know that many of these patients will later have LV dysfunction. So that is the level of our understanding what we would use going forward, as far as someone who has acute LV dysfunction, regardless of the cause, whatever leads him to recovery, there is a subgroup of those patients who may have more triggers down in their life, either with their comorbidities or other things, which will still lead to chronic heart failure. So, and advanced heart failure essentially is a clinical circulatory compromise which requires special care and whatnot. So there is a it's a nuances of advanced heart failure versus end stage heart failure, which is a final common pathway for which will lead to advanced therapies either for heart transplant or a ventricular assist device. And again, compensated and decompensated heart failure, we all know that if a patient comes in right to the hospital and now he gets stabilized, whether he remains independent on inotropes or end organ dysfunction, and what determines compensated versus decompensated heart failure. Now, I think part of this, these are all a simplistic way of looking at different stages of heart failure. Like, let's take an example. In this audience, probably more than 50% of the audience in this will have a risk factor for heart failure. So technically, 50% of the people sitting here will have stage A heart failure. Right? Someone with hypertension taking medicine, by definition, he has stage A heart failure, which means that it's just a mindset of how do we think about this whole thing and what do we do? Heart transplant is really a very small portion of the advanced cardiac therapies, right? So if we identify and categorize and follow these heart failure patients in an appropriate terminologically correct and proper way of communication probably is one of the key messages for a non-cardiology audience, what I would think. Yeah. So we, essentially deal with the stage C and stage D heart failure, which I think the previous speaker has alluded to. So coming to children, right? Let's take an example of our own center. We do about 2,500 or 2,500 cardiac surgeries a year, right? About 5% or 10% of them, they go home with LV dysfunction because of their preoperative stage. So you imagine how many of those patients eventually will get normalized or not. So that is a level of assessment what we need to be doing and diligence, because we are living in a world of increasing aspirations, more accountability. It is not a simple a PDA device closure or a ASD device closure or what we think is a simplistic solution to a problem. Someone comes with a let's take a 10-year-old child with coarctation of aorta, LV dysfunction. It's invariably well recognized even in a small town, because he gets to a healthcare facility, gets an echo, gets the diagnosis, probably gets treated there. But that used to be the case 10, 20 years ago. Now, going forward, that parent will demand 5 years down the road if he dies from LV dysfunction. So we didn't do much better just by treating that isolated problem. So every day, half of the patients what I see is all from previous history of corrective surgeries, and if they're repaired or unrepaired and whatnot. So that's not because we didn't apply our mind, that's just because of better recognition of things. Yeah. So again, infants, toddlers, and school age and adolescent children. So the broad message here is, can a child perform what he's supposed to do? A 7-year-old going to second standard, if he stop going to school for 6 months with ventricular dysfunction, that's a problem. So in our mind, he's advanced heart failure, he's going to end stage heart failure eventually. That's just because the parents are not unable to verbalize that he has stopped going to school. Because he just doesn't have enough cardiac output, he just stays home, eats, doesn't play. So that is atypical for a 7-year-old. So the recognition of advanced heart failure is about what you're supposed to do, as we went back to the basic definition of the inadequate cardiac output. Now, I think I briefly alluded to the CHD and the cardiomyopathy. If you look at all the corrective surgeries, whether it is pediatric or adult, right? Once we intervene for a cardiac lesion or a valve, and once they have dysfunction set in, there is a portion of these patients, of course, there are many molecular mechanisms into who may or may not, and we really probably don't have understanding of that quite yet. But there is a good portion of these patients, despite their corrective treatment and surgery, once they have severe dysfunction set in or moderate to severe dysfunction set in, unless they recover, if they continue to have dysfunction, despite their not having symptoms, they should be really closely followed. How frequently and how deeply we follow, it's up to the individual clinician to choose. But so things are times are changing, and hopefully we can do better of this. Again, this is a very simplistic way of assessing a warm and a cold congestion model. A patient comes in, this applies to both probably children and young adults. Someone comes with cold shock, he will be at a highest risk of death as compared to someone who walks into the OPD warm and dry, what we call. Yeah. Again, I think Aditya has already alluded to this mnemonic of advanced heart failures. Again, impaired quality of life. You just ask, what does he do? How is his quality of life? This applies to anybody, adult and a child. Was his health the same this year compared to last year? How many admissions he has had? Has he stopped going to his job or work? It will clearly tell in 2 minutes. We can. So that probably itself is enough to know whether he is progressing in his disease or not. Transplant is really not the answer to everyone, but transplant is one of the options. But trying to understand the trajectory of the disease in relation to what the patient tells us is the most critical aspect of how we assess a patient, with conjunction with imaging, laboratory parameters, and clinical exam and whatnot. Again, if you look at the cardiac hospitalization, it triples 1-year mortality. So 1 in 10 die within 30 days. again, there is a series of things which, which will help to understand, general predictors of poor prognosis. But if a patient comes into our OPD, our OPD, who are funneled in with advanced heart failure, right? Someone with low EF, they send into, someone who is interested in heart failure or who does it. The first thing I would want to know is, what is his risk of death in the next 6 months or a year? Yeah. We really don't have data, but once we start looking at it scientifically, we know, at least in our own setting, that half of them are dead by the end of 1 year if any call back. So we have a large, probably more than 300 patient database, both short term and long term. Now, if we have a better clue if he's going to die with a flip of a coin within 1 year, you better do transplant and not be on medical therapy. Right. Now, again, the median survival of heart transplant patients, depending on the demography and whatnot, it's about more than 12 years. So with stage D heart failure, as we know, it is less than 2 years. So even from a cost benefit standpoint, once we know the nuances of the progression of the disease and the particular patient's background, this would be one of the, probable ways to give him a better quality of life and lifespan, I would say. So, technically it's a stage 1, class 1 indication. Again, I will just briefly go over a case scenario. 12-year-old boy, class 3 heart failure, unable to go to school, multiple admissions. He comes into the OPD, he talks, he sits in the chair, he can do the translation to his parents. You cannot tell him that he has end-stage heart failure unless you know his imaging and biochemical parameters and whatnot. Yeah. So, he presents with a warm shock. What, if we go by conventional criteria. Cardiomegaly, he's a typical case of a dialytic cardiomyopathy. Let's see. We'll just keep through this. Yeah. So this was, many years ago, we did the first one of the younger patients in Karnataka here at 4 years of age. And so any organ transplant, for example, it doesn't have to be for the heart. Any disease donor transplant requires a lot of coordination. More than 100 people work for the first 12 to 24 hours to get a heart, to get it successfully until he really starts recovering in the ICU. So there is a lot of planning and coordination involved. Yeah. Thanks. We'll keep all the questions at the end. Thank you.
Next, we'll have Dr. Shrikant. He's a consultant cardiologist at Narayana Health. He'll be talking to us about evaluation process in heart transplant.
Good evening, everybody. So, coming to how do we evaluate, it's very important that timely referral is a very important part of the managing patients with advanced heart failure, which evaluation happens at the centers other than the referring centers. So how do we work up is what we'll discuss. So heart failure, we just heard there is an underlying disease as well as multiple comorbid conditions in patients when we are discussing in adult heart failure patients. And it's very difficult to give them guideline directed medical therapy, and managing the reversible conditions is very difficult in a class 4 stage D patients. And when it is inadequate, we take them for either transplant or mechanical circulatory supports. And if the referrals are delayed, many times we may not be able to give them intervention, which we really want. And the other thing is we are getting new medications, newer devices. We are changing, protocols are changing rapidly. Our skills are improving. So there is a dynamic thing. So none of the centers have a definite thing. Whatever we discuss one day, we keep changing, we are keeping evolving, newer medications are available. That all improves our patient outcomes. So the median survival of heart transplant is around 12.2 years and LVAD is around 7 years. So we just heard which kind of patients we are discussing. Since the transplant outcomes are improving day by day, every year the data is only showing better outcomes, we should consider referrals for either one of the therapy when the patient deserves. And So any patients who is having an ongoing heart failure symptoms should be considered for evaluation. And if there is a risk of disease progression, if you suspect the patient is progressing, he should be referred for evaluation. If delayed, they become ineligible for advanced therapies. So essentially, he will undergo a risk assessment. He will get a education about how to manage his heart failure, and he can get involved in some investigational trials. And especially the most important thing is about discussion of the prognosis, which we just discussed. The prognosis is not good for advanced heart failure, so that has to be communicated to the patient. And even if there are certain conditions like renal insufficiency, liver dysfunction, frailty, RV dysfunction, pulmonary hypertension, a referral is always important because many of them can be reversed or some of them are reversible. A temporary circulatory support may improve the quality of life and parameters, and which may make him eligible. And the best patient outcomes are ones who are stable before they reach for transplant. So whenever a patient walks into a transplant evaluation, we have to establish that the patient has a low cardiac output. I think we all already discussed what are the prognostic tools, clinical, biochemical, imaging, and hemodynamic parameters. Dr. Aditi just discussed. I need help, a very useful mnemonic to make sure the patient is having LV dysfunction and has a low cardiac output. And we have to go through a history, make sure he's adequately following the medications, he's following the advice, and he's reaching the guideline directed medical therapy, clinical assessment to see if he's congested, what can be acutely done, a routine evaluation has to be done, biochemical parameters to correct anything, and imaging, echo, strain rate imaging, cardiac MRI, PET, all of them can figure out if there are any reversible conditions which have been not been evaluated. NT-proBNP also discussed, not only the current thing, if there is an increasing trend, and the device interrogation. The patient has atrial fibrillation, flutter, CRT is not pacing, whether he has arrhythmias, all can be evaluated when he comes. And if he has undergone an angiogram, what is the extent of revascularization? Can there be any additional revascularization possible? All can be evaluated at the initial stage. Then we come to the evaluation, decision that whether this patient needs a transplant or LVAD or not. So cardiopulmonary exercise testing, we just heard what to do. On beta blocker therapy, more than 12 VO2, peak VO2, we don't consider them for transplant. Or not on beta blocker therapy, more than 14, various other parameters are there to find out whether they are at risk, high risk, or intermediate risk. And if we decide not to transplant, repeat the CPET after 6 months. And if it is consistently more VO2, peak VO2 more than 14, don't worry, he's stable. Call him after 6 months. If there is a change in the peak VO2 or reduction in peak VO2, consider for further evaluation. Right heart catheterization, another important tool to ensure that the patient is receiving optimal medical therapy. If there are any parameters which can be addressed to make him better, or the parameters better, can be considered. Up titration or down titration of diuretics can be considered. Any parameters like BP less than, systolic blood pressure of less than 90, cardiac index less than 1.2, and wedge pressure more than 15 are all suggestive of we are looking at a sick patient and probably he deserves a heart transplant. We also can assess whether this pulmonary vascular resistance is too high. Time and again we hear about timely referral because over a period of time his pulmonary vascular resistance keep increasing, and if there is an irreversible damage to the lungs because of the elevated left atrial pressures, we will not be in a position to transplant him. So if we see a pulmonary vascular resistance more than 5 Wood units, index more than 6, transpulmonary gradient more than 15, and or pulmonary systolic pressures more than 60 plus one of the above, we may not consider for transplant. He will not be eligible for transplant, or we have to reassess after optimization. We can use vasodilatory challenge, and if the blood pressure drops to less than 85 before we reach the required PVR, again becomes a poor prognostic factor. If the patient is on inotropes, that itself is an indicator that he's having low cardiac output. And if on stopping inotropes, if there is an increasing creatinine or arterial lactate is more than 2.5, if he has a central line, mixed venous oxygen saturation of less than 50% or cardiac index less than 2.2, if you stop the inotropes is deteriorating, again, is an indication that we have to transplant. And if there are any correctable conditions like atrial arrhythmias, left bundle branch block, which has been not been treated with a CRT, or if there are any valvular pathologies, now we have a, we can do a mitral regurgitation can worsen their heart failure outcomes. We can do mitra clip or other way of addressing the regurgitations. If there is a need for revascularization, again, will change his outcomes. So all of them can be considered. However, patients with severe coronary artery disease with intractable angina and no revascularization options, these all parameters, whatever we discussed, will not hold good. We direct if he's not very enthusiastic about his own health, we should consider what is the best thing to do. So it is very essential that they maintain their immunosuppression and come for regular checkups, not skip their medicines, and any psychological aspects or cognitive or functional abilities which impair are to be taken with precaution. Mental retardation, stroke with residual effects, and tobacco usage or alcohol dependence, non-compliant to medications are all reasons why we should be careful. And family support is very important to make sure that they have family support as well as financial stability. So when we decide, okay, if the patient requires a transplant or LVAD, if he's suitable for both, we list for transplant and wait. If he deteriorates suddenly, then only we go for LVAD. If he's eligible for transplant but not LVAD, list for transplant. And if he's eligible for LVAD but not for transplant, then we implant LVAD and reconsider transplant at a later date. And if he's only eligible for LVAD, we go ahead for LVAD. LVAD being expensive, we don't have this kind of a luxury all the time. So multidisciplinary therapy or team meeting where a heart failure cardiologist, imaging specialist, where we have had a adequate imaging of the vascular tree, cardiac, MR and echo are a part of the discussion. And cardiac surgeon, anesthesiologist, and cardiac intensivist also assess the patient. We need assessment from the psychologist, social worker, dietitian, physiotherapist, heart failure manager, and other important, all the other specialties having assessed and making sure that he is doing well. And immunological workup, we just heard a lot about it. It helps us in planning the kind of immunosuppression we plan. If the patient is not eligible for transplant, reassess every 6 months, either for candidacy or for palliation. And a CPET can always be done. If he's too good for a transplant and sending home on medical therapy, we send him for transplant, and everything else fails, he will be sent for palliation. So confirmation for a transplant indication, ruling out contraindication, and selecting the right part for transplantation is what we do when we evaluate a patient for transplant. Thank you.
Thank you, sir, for that very detailed talk. Next, we have Dr. Bhagirath Raghuraman. He's a senior consultant cardiologist and medical director of the heart transplant program at Narayana Health. Sir will be talking to us about long-term outcomes after heart transplant.
Thank you, Aditi. Good evening to all. Good evening, Rajni Madam. You've helped us a lot in this journey. So I take this opportunity on this podium to acknowledge your efforts. So long-term outcomes following heart transplant. Well, I think long-term is because we started our journey way back in 2008. And by long-term, I mean, we had to face this fact wherein every patient that I evaluated, they would ask me, how many transplants have you done? And the answer would be that this patient is the first one. So it started from there, and then we eventually reached here wherein we've done more than 70 patients. So with this, I start off to introduce this topic that, of course, cardiac transplantation is the gold standard in terms of treatment. Now we've come a long way in terms of immunosuppression, and the median survival is 10.7 years and counting. Every graft failure, early graft failure and multi-organ system dysfunction are the most important cause of morbidity and mortality. So we have to continuously assess these patients. And of course, the early graft failure usually happens, you have multiple organ dysfunctions, and the late mortality includes malignancy, rejection, infection, and cardiac graft vasculopathy. So whenever the patient comes to us for evaluation, when I do the biopsy, I used to do the angiogram initially, but now I understand that we'll have to do an IVUS or even an OCT to assess the wall of the blood vessel, because the difference between coronary artery disease and the cardiac graft vasculopathy is that this is circumferential and it is more or less across the entire length of the artery. So it is better picked up on an IVUS or an OCT rather than a conventional coronary angiogram. Chronic renal dysfunction, as we see, almost about 6 to 10% of our patients are in chronic kidney disease. We have the nephrologist team on board who assesses these patients. None of them, however, have undergone dialysis, though statistically they say that if the patient has had a cardiac transplant of more than 10 years standing, almost 6.2% of them would require dialysis. Fortunately, we've not faced this scenario. Functional outcomes, only 26% of patients go back to work. So which means that almost all of them are supported by the family. So this makes it really important. In fact, I take this opportunity to tell you the story of my very first patient, Vamsi Krishna, who's completed 15 years, 3 days back. He was working in a prominent NMC. He had this left ventricular, he had a biventricular dysfunction. Because of that, he had exhausted all his medical leaves. He was terminated from service, came to the steps of Narayana Hridaya and collapsed, had a cardiovascular arrest, and we revived him on the steps, carried him up. At that time, I was frantically trying to get the ambulance, which had gone away to Ballari. I put him in the back seat of my car and brought him to Narayana. For our luck, that very night he got a cardiac transplant, and he woke up with a new heart.
And this man from there built up his life. He had lost his job. He started his own company. Today he has 150 employees. He's made an insurance for them to cover transplant because his company did not offer transplant. So this is kind of a life-changing, event that he went through, which brought us this far. Real encouragement to see Vamsi even today. He plays football, he plays table tennis, he's living his life to the fullest because this part of life even we didn't expect. So apart from him, there are very few of the patients who eventually work because most companies are frightened to give them insurance. So as a result of which they don't even employ them and they don't want to take the responsibility. But I must say that most of them are very good, very intelligent and very creative. We have a number of patients who have started their own jobs and are doing well. High incidence of depression. We've had 3 patients who've sought psychiatrist help. And of course, these are opportunities for research. So statistics at a glance, 82% 1-year survival, 69% 5-year survival. Highest mortality is in the first 6 months. We are extremely encouraged to take up the patient for a transplant, but we have to be very, very vigilant because many of them recover in 2 weeks and are ready to go home. But the highest mortality happens in the first 2 to 3 months and is highest up to 6 months. So we have to be extremely careful for these patients. Also, after the first year, the mortality decreases by 3.4% every year. So keep them going, frequently keep monitoring them. And of course, the conditional median survival, this is an important viewpoint. The time point at which 50% of patients who survived the first year are still alive. That is 13.3 years for an adult heart transplant. The frequency for retransplantation, fortunately, we haven't had this scenario, but 2 to 4% of them would require this. So let me quickly run through the important outcomes by terms of organ system, because the topic given to me is long term. That means what? It's not only cardiac, you have a multi-system involvement. So there can be neurological outcomes. Some of them can have a cerebrovascular accident. It's reported in nearly 13% of our patients, of the heart transplant patients. Fortunately, we didn't have any. The perioperative period, they can be delirious. They can have encephalopathy in almost 9%. Polyneuropathy, 70% of patients can have some form of polyneuropathy, and pain and depression in 15 to 37%. Respiratory outcomes, there are significant changes in pulmonary function. I oftentimes used to wonder that these patients are extremely breathless. So what you do an angiogram, you find that they are totally okay. You do a pulmonary function test, they are totally okay. But put together, this patient is not able to do well and still has breathlessness. So then I have understood over the years that there is an alteration in the pulmonary diffusion. Sometimes they retain carbon monoxide. So this is an important thing that you need to do to keep in mind when you assess these patients. Gas exchange impairment persists in 67% of the patients. So they are quite breathless when they do small amounts of effort, but many of them recover completely. Abnormal pulmonary exchange contributes to limited exercise capacity. I used to think that once you change the heart, they should be able to do that treadmill like a song, but that doesn't happen. And that's because they have this gas diffusion problem, but that soon settles down. And many of them are into active sports. My patient Sriram Satish won the gold medal in table tennis in the recently concluded transplant games. Extremely fit person. And now I understand that it's the way you train yourself after a transplant that determines the journey ahead. And of course, there is exercise-induced hypoxia. The cardiovascular outcomes are graft failure, most common cause, early incidence of graft failure, risk factors. This includes prolonged graft ischemic time, male recipient and female donor, high pulmonary vascular resistance, recipient high creatinine or dialysis, and of course, if the patient is on mechanical circulatory support. The other is that the cardiac graft vasculopathy. I told you that we use IVUS. The incidence is at 7.8% at 1 year and rises to about 50% at 5 years, contributes to more than 10% of deaths. Again, the risk factors are male gender, ischemic cardiomyopathy, and so on. Due to denervation, atypical symptoms, they don't have chest pain. So now how do you really assess these patients? They come with exertional dyspnea, GI symptoms, heart failure, or arrhythmias. So this is the way forward to assess these patients, whether they have coronary artery disease. No nerves, no pain. So they don't present like the conventional patients. Renal outcomes, I told you many of them enter into chronic kidney disease. Several of my patients are in early CKD, stages 1, 2, or stages 3. None of them fortunately required any dialysis. Endocrine outcomes, a majority of them become diabetic, almost 23 to 39%. within the first 2 to 3 years. Many of my patients who are 17, 18 years old are already diabetic, and they come and tell me, see, my heart is fine, but you've made me diabetic. Now, this is a tricky situation, but what to do? This is the price to pay for having immunosuppressive medications on board. The risk factors include age more than 50 years, non-white race, body mass index more than 25, pre-transplant ischemic heart disease, and recipient CMV positivity, tobacco use, and so on. Immunological outcomes, rejection. I think often this has been discussed in great detail. Acute rejection, the acute cellular and antibody-mediated rejection. As per standard protocol, you give them steroids, and then where the AMR is more severe, you up the ant by including rituximab and other complement antibodies, and IVIG where necessary. Infections, 13.4%, they contribute to death within the first month of transplant. So you need to look at them more carefully, screen regularly for infections, and of course, vaccinations and other things as per protocol. Bacterial septicemia, viral and fungal diseases are common in these patients because they are immunosuppressed. So screen them regularly and keep monitoring them. Malignancy, again, very common. Skin is almost 18%, lymphomas 1.9%. And apart from that, a host of other malignancies like prostate, lung, bladder, Kaposi sarcoma, breast, cervical, colon, and renal cancers. Fortunately, none of our patients have had carcinoma or malignancy till date. Now, I'll just run through the ISHLT data because it's about long term. So if you see the ISHLT data, recipient age in adult transplant is 54, is the mean, the age of the recipients. Most of them are male, 77%. Recipient times up. Okay, so recipient pre-transplant ECMO and so on. So you look at the various profiles, EGFR and so on. Majority of them are ischemic heart disease. I think Aditi had already explained one of the patients who came in with a post myocardial infarction. He had reached the hospital the next day after an MI, completely destroyed anterior wall, EF of just 15 to 20%. And at 26 years, he's a myocardial infarction survivor with severe LV dysfunction. What do you do with this patient? Obviously, transplanted him, and he got away with it. The other Kaplan-Meier freedom scales, I'll just rush through it. Decrease, yeah, I'll just finish in a minute. So freedom from death or retransplant, you can see the curves. So the adult curve is placed in the second position. And of course, this is freedom from death and retransplant for adult heart transplants by the transplant era. So if you see the 2010 to 2017, this is the ISHLT data. This appears to be the most promising. Apart from this, the freedom from death and retransplant for adult heart recipients based on the sex of the patient. So whether it is female or male, you can see that the females fare better in this particular patient profile. By EGFR, you can see that particularly in this patient profile, the median death is given in less than 30, it is 7.2 years, 30 to 59, 10.3 years, and more than 60 is 12 years. Now, apart from this, I'll just rush through the overall survival based on the other factors. I'll just show this. What are the continuous factors that affect long-term outcomes? The recipient age, recipient BMI, EGFR, donor age, and ischemic time. So the sweet spot, if you look at recipient age, if it's in the range of, you can see that around 40 to 50 years, that's the best spot. Recipient BMI, approximately around 25. If you look at the EGFR, it is in the range of about 90 to 100. If you look at the donor age, the younger the donor, the better. At least the sweet spot is around 30 to 35 years. Ischemic time, make it as early as possible. That is facilitated by the Jivasarthakate so that we get the heart in good time. And of course, this is a snapshot of what are all the factors that can affect the long-term outcomes, be it ECMO, mechanical circulatory support, and so on. So this is a snapshot of our outcomes. Total transplants we've done is 70 till date. We have 39 who are alive, 31 died. Now, let me tell you, it may look that it's like a 50-50 kind of a scenario. But the reason is, once the patient crosses 1 or 2 years, they follow up in their respective states. And it is followed up oftentimes by a general cardiologist, non-transplant cardiologist. We've had many of our patients whose immunosuppression is monitored by the nephrologist, and they don't come for biopsy to us. So we've now streamlined the entire process, and we have good statistics now that is available. Our 10-year survival is about 44%, and 5-year survival is about 65%. 1-year survival is 77%. So this is our fact file that I present to you. Thank you for your attention. We take the questions now. Aditi, Srikanth, Shashi, come. Questions, or everybody is hungry and tired? We can move on to the next session. Yes, so that is the left ventricular assist device. We've done 13 patients till date. One of the things that intimidate us is the cost of the left ventricular assist device. We have the HeartMate 2, which costs about 45 to 50 lakh rupees for the patient, and the HeartMate 3, which is about 85 lakh to the patient. Fortunately for us, since the left ventricular assist device is fairly expensive, the hospital has completely waived off all charges, including surgery, including the length of stay, the ICU stay, medicines, everything is totally free. But still, it costs nearly 1 crore to go back alive. Now, one point that I must mention here is left ventricular assist device will support only the left ventricle. So if the patient has a right ventricular dysfunction, you many times may not get away. So we have many ways in which we assess the right ventricular function, whether he is suitable to get away with a single support device. Otherwise, you'll have to put what we call as a total artificial heart. Now, total artificial heart, the Syncardia company approached us. It costs 1.5 crore. I think at this point in time, affording that kind of equipment is fairly out of reach for most of our patients. So we've not done any total artificial hearts, but the LVADs, we've done 13 of them.
What company manufacturer?
Yes, it's made by Abbott. HeartMate 2 is due for withdrawal because it's already phased out. The incidence of thrombosis is slightly higher. HeartMate 3 has a very, very low incidence of thrombosis. So in about 6 months downtime, we'll be left with only the HeartMate 3, which is about 85 lakh rupees. Basha sir.
Treatment option for heart failure with preserved ejection fraction.
Yes.
They are having same bad quality of life, repeated admission.
Yes. So the
transplant an option.
Yeah. So the current, as per the current data, the medical management would include basically diuretics, and you have the SGLT2 inhibitors. These are the two proven ways in which you can manage heart failure with preserved ejection fraction. Of course, a host of other medicines are also tried, but you don't have much convincing data to support the use of any other medicine. Now, there have been trials which have looked at whether you can use cardiac resynchronization therapy in such patients or a VAD in such patients. But these are purely trial, purely anecdotal. You don't have substantial data to support its use. Heart transplant, still no center has done heart transplant for purely heart failure with preserved ejection fraction, because you still cannot be sure that the long-term survival would be good enough in such patients. So it is still a matter of conjecture and does not figure in the guidelines as of now. Looks like only I'm answering. Srikanth, sorry.
So just to add to that, HFpEF is also a heterogeneous group of diseases. So if you're talking about HFpEF that is associated with comorbid conditions, obesity, diabetes, as Sir said, you have to manage the comorbid conditions, and SGLT2 inhibitors, diuretics are your mainstay. But heart failure with preserved EF can also be from conditions like restrictive cardiomyopathy, like amyloidosis, hypertrophic cardiomyopathy. In those conditions, even if the EF is 40% or 50%, if they have end organ dysfunction, low blood pressure, and all of the conditions that any of the conditions that we discussed in our previous talks, those patients can also be considered for heart transplantation. So I think with that we'll end, and we'll have our next talk will be online by Dr. Subramaniam Swaminathan. He is the Director of Infectious Diseases and Infection Control at Gleneagles Hospitals.
Good evening, everyone. Thank you for inviting me. My apologies for not being there in person. So without much ado, let me start off with my slides. Let's see if I can share it from my end. Otherwise, you guys can help me. I trust you guys can see my slides. Yeah, okay. So I know you can. Okay, good. So these are my disclaimers. So I work with a team of really intelligent people and very smart colleagues of mine. And we get to see a lot of different solid organ transplants, including lung, liver, heart, kidney, hand, pancreas, small bowel, uterus, all kinds of stuff. So obviously, the general principles in any transplant is pretty much the same. Before we start, it's good to have a good baseline and to understand who the patient is, why the patient is undergoing a transplant, and a lot of the circumstances around it, and making sure we mitigate the problems for the recipient as much as possible. So we look at it in two parts, first the donor and then the recipient. So we'll do it in two stages. I'm going to go through this very quickly. There are lots of guidelines. I'm just going to summarize why the guidelines are there. So for the donor, from the donor side, we really don't want the recipient picking up an infection from the donor. There's a slightly older article from the West, which looked at potential donor-derived infections, which can be pretty bad, sometimes even fatal. Lots of diseases, including and up to rabies, have been reported in recipients, especially from cadaveric donors, and therefore we need to be very careful in screening all these people. There are clear guidelines on who we accept as cadaveric donors. And it's all a process of measurement and assessment and documentation, and we just need to do it stringently. So how do we risk mitigate? You first stratify by medical and social history. We also examine both the donor clinically and look at the organ as well grossly to see how it looks. And of course, there is laboratory screening of the donor. Problem is very often, if it's a cadaveric donor, the time is very limited. So for organs like heart and lung, which is completely cadaveric, you have very little time. But you can get as much data as possible, including medical history, previous hospitalization, surgery, if the person was a smoker, all kinds of stuff. And of course, serologies and cultures if it's possible. And you also want to know why the patient is brain dead, because you really don't want to take a CNS infection, especially viral meningitis, because viral meningoencephalitis, because those things can transmit to the recipient as well. So testing, by and large, we do the three big ones, which is HIV, HCV, and hepatitis B. Very often, we don't have time to do the other serologies. So it's a bit of a problem. TB screening in the donor is always more complicated. Living donors, again, it's not an issue for heart and lung transplantation, but for other solid organs, we always look at living donors very carefully to see if there are specific risks in them which can be transmitted. So obviously, that's just one half of the whole picture. The second half is the recipient. So in the recipient, it's good to have as much data as possible and as much time with them as possible. We want a full medical history of everything, including drug allergies and things like that. We really don't want to be surprised with the sulfa allergy at the back end, because in heart transplant, toxoplasma is a major issue. And if we can't use cotrimoxazole, that's a big deal. So you want to know all of this, pneumocystis as well. So you need cotrimoxazole. So you want the full medical history in terms of all their previous medical issues, including tuberculosis, current and past medical issues. What are the current medications? What things do they need? What interactions do they have? And we also want to know about the vaccination status, because many of these things are vaccine preventable. And studies have shown that vaccination actually promotes long-term better outcomes. So we also look at allergies and all that. I just mentioned this. Obviously, the skill of the team becomes a big issue. Large volume centers like what NIH has been doing obviously have very good skills, and that makes a difference, because there's a curve in terms of the skill set and the complications for the patients. Like they just mentioned, the point is that we learn from our own experiences and we improve on it. So you have better survival with more mature transplant teams and large volume centers. Obviously, we also have high-risk situations like mismatch transplant, or when you have transplant across blood groups and things like that, or if you're using some really high funda agent like rituximab and alemtuzumab and all that, those require additional support and monitoring. I'm going to discuss this in the form of few short cases. This is these are all not made up cases. All of these are real cases. This is a 55-year-old lady who was being evaluated for a renal transplant at our center. And she had come here with her brothers. And one of her brothers had chicken pox just recently. And she was staying, all of them were staying together in the same hotel. And the nephrologist immediately asked me what needs to be done. And we did varicella zoster serology, and she was seronegative. The reports came back a few days later, and she was seronegative. So the nephrologist immediately ran and gave her the chickenpox vaccine. But the problem is it's a little too late for that, and she develops a vesicular rash, and you know it's chickenpox. So she gets a acyclovir. Couple of weeks later, she undergoes a transplant. So the point is that in this case, we knew there was a clear exposure, so we delayed the transplant. Sometimes you don't know where the exposure is, and it can lead to nasty surprises. And you really don't want things like chickenpox happening during the transplant. So it's worthwhile checking for this and vaccinating them and making sure they're immune, because if you can prevent it, it's always better. Another situation, this happened in a Hyderabad center. Gentleman with alcohol-related liver disease had multiple taps for ascites and also pleural effusion. And because he had recurrent massive pleural effusion requiring pleural tapping, outside somebody had done a pleurodesis and about 6 months prior. Within 2 months of transplant, he became very sick. He had lung changes, worsening graft, and long story short, he died of lethal extensive aspergillosis. But the question is, where did the aspergillus come from? Well, looking back, it was clear. They had used talc for pleurodesis. And talc, being a biological material, is often contaminated with fungus. Now, in a person pre-transplant, the aspergillus spores may not have provided a big challenge. But in post-transplant situations, these aspergillus spores can be absolutely catastrophic. And this patient died of a problem which probably could have been prevented. Obviously, this requires a lot of planning, even pre-transplant, so that we handle them very carefully and we don't end up, making them a ticking time bomb after transplant. So we talk to a lot of our patients about post-transplant living. We tell them, guys, please take your vaccines, because every time you have a fever, it becomes very challenging because it increases the risk of rejection. You end up with a large bill with the workup for fever, and it can lead to secondary infections and things like that. So getting the flu vaccine and stuff like that is definitely useful. You want to prevent problems. Good monitoring and follow-up that was mentioned in the previous talk, because you really want to make sure that you're on top of the immunosuppression. It is not too much, it's not too little, it's just right kind of thing. I know I'm sounding like the Goldilocks and the Three Bears. And of course, avoidance of infection. Everybody talks about wearing a mask. Well, even during COVID, we knew how diligent we were with masks. Everybody was wearing a chin mask. So things like that doesn't happen. Hand hygiene is obviously very critical. Even at home, hand hygiene is useful because respiratory infections are a major deal even in our country. Food and water safety is another thing that we focus on. We talk about food management and making sure milk is boiled, water is safe, all that stuff. Animal contact can be tricky, especially because they can be carriers of a lot of infections, and birds can carry a lot of fungus and things like that. Many of our patients are traveling very far and wide, so you really don't want a post-transplant patient coming and telling you, I need the yellow fever vaccine, because you cannot give it to them. The yellow fever vaccine is can be lethal in patients post-transplant. So a lot of these things can be done, a lot of planning can be done pre-transplant, and the counseling has to be given to the patient because you don't want to have a nightmare scenario. So obviously, you tell them to keep away from sick people. You don't want sick people to come and meet you, away from crowded places and things like that, especially in the recent post-transplant setting where your immune suppression is very high. Hand hygiene is absolutely critical. And vaccinating contacts is also a measure that's used in the Western world, not so much in our country. Food and water, absolutely important. Boiled water or equivalent, pasteurized milk, avoiding raw fruits and nuts. Grapefruit is another important thing which is gaining popularity as a health fruit, and it's there in a lot of mixed juices. This has tremendous interactions with your transplant medicines, and it can make it miserable. It can be like my life miserable. Food handlers also need attention, and they need to be careful. So yes, we want to take as many precautions as possible. And the idea is to tell our patients to enjoy life responsibly. And that is important. It's not that they cannot enjoy life. We just want them to be responsible about it. This is another true life scenario from one of our Hyderabad patients who underwent a liver transplant in 2011. 3 years went by. His transplant was doing well. He was doing well. And then he went home and he presented to our hospital with the upper right photograph that you see with that black stuff on his on the tip of his nose. He was seen by a physician outside who said, oh, you got an infection, and gave him Augmentin. A couple of days later, he presented with the lower panel. You could see that the whole nose was sloughing off. And in fact, one of his eyes had become red, and the biopsy showed zygomycosis. So this is a catastrophic situation. How do you treat this? You do surpanaka, cut off the nose, give them a lot of antifungals. This patient actually survived. He needed to have plastic surgery 6 months later. But the question is, why did this happen? The point is, he said, look, I was celebrating because I had been doing very well for 3 years post-transplant, went back home and participated in a bullock cart race. And in a bullock cart race, the amount of dust that comes up, which is spores ridden, obviously can cause this kind of a problem, even in a person with very little immunosuppression. So it's important to understand that these people need to be careful lifelong, and it's not a one-time deal. Obviously, it doesn't mean that they can't do anything, but they can't take unreasonable risks like a bullock cart race or trying to do something which is really, really crazy. And I think this is where education of the patient is absolutely critical, because it's about enjoying life reasonably safely. Obviously, in the infectious diseases, we really cannot forecast everything that's going to happen down the line. We want obviously something which is this simple, where we can literally look at it and say, this is what it is. But see, that was so simple. My job be taken over by ChatGPT. Thank God I cannot be replaced that way. I'm confident of that. But having said that, the idea is to prevent the need for reaching out to an infectious disease specialist and say, my patient needs help. And the best way to do that is to prepare well, to educate your patient, and to make sure it is done in the safest possible manner so that you achieve the best long-term outcomes. Thank you.
Thank you so much. Thank you so much, sir, for that very insightful discussion. I hope my voice is clear now.
Absolutely.
I'd like to start off with a question. In the Indian scenario, compared to Western countries, what are certain additional factors that you have to be careful about, and how do you tailor your approach in this setting?
Okay, so the tailoring of the approach starts with a couple of things. Number one, our patients are more protein malnourished and they are more antibiotic experienced before transplant. So our patients need to have a period of antibiotic free period as much as possible, because you don't want to have too many MDRs going into the transplant. So our patients carry more drug resistant organisms, and the infections after transplant also tend to be more horrible. That's a serious issue. Number two, we have more fungal burden than the Western world, both inside the hospital and outside the hospital. So in the hospital, implementing ICRA guidelines and things like that really make a difference. It's more important than HEPA filters and things like that. Post-transplant also, there is a higher fungal burden. We are a tropical country. We are an agrarian country. There's a lot of construction happening. So we see a lot more fungal burden. That's another thing. The third thing is we see more community-acquired respiratory infections and things like that, which is a major issue. One more thing is that a lot of people ask me, should I go for CMV prophylaxis or preemptive and all that stuff? In the Western world, it's easy to do preemptive because they have dedicated manpower literally following every patient and haranguing them, saying, what is your symptom screen? Where is your PCR? In our country, I have realized, I'm sorry to say this, that taking responsibility is not something which is very popular. And therefore, most clinicians don't want to get burnt, and therefore they end up using universal prophylaxis, at least for CMV. The problem is also that we also tend to over-prophylax with all kinds of medicine in an attempt to try and see if we can somehow cover all bases. That is also a polar idea, which is not necessarily good. I think we need to have a reasonable state of equipoise where we do enough for our situation, but not do too much. Another example is, say, tuberculosis. A lot of people have asked me whether we should use isoniazid in our patients who want to go transplant. Our own experience, the answer is no. Lung transplant, we routinely give them isoniazid because it's very difficult to stratify. But we have done more than 2,000 liver transplants. And how many post-transplant TBs have I seen? If I exclude the patients who took TB into transplant, I think the number is less than 10. So why am I getting worried about this? See, the data about TB in transplant is from 20 years ago, but the situation is very different. Today, the situation is very different. So I think there's a lot of things which the ground is changing right under our feet. In the last 20 years, our immune suppression is a lot more gentle as compared to the Western world. So a lot of things are different. And I think it's important for us to not blindly adapt Western guidelines, but to understand the principles of it and to adapt it to the Indian conditions, understanding the epidemiology of diseases here.
Thank you so much, sir. Any questions from the audience? Thank you so much for joining us, sir.
Absolutely a pleasure. Please take care.
Next, we'll have Dr. Ankit Mathur. He's the Additional Medical Director of Transfusion Medicine and Transplant Immunology at Rotary TTK Blood Center, Bangalore Medical Services Trust. Sir will be talking to us about basis of immunological evaluation pre and post transplant.
Good evening, everybody. Since we are almost at the end of the session, I will quickly discuss about HLA and transplant immunology, which is a common area of discussion, whether you talk about kidney transplant, liver, lung, or heart. So whenever we discuss about the transplant, first question which we have in the lab in our mind, or even in the clinics with the doctors, they have in the mind, whether my donor, whether my patient has any HLA antibodies which might react with the donor cells or not. How these antibodies are developed? These antibodies are developed from blood transfusion, pregnancy, and if the patient has underwent any previous kidney or any organ transplant. And these antibodies can cause antibody mediated rejection, which none of us want in our patient after transplant. Many years ago, these two scientists, Patel and Terasaki, described how important to find out preformed antibodies in the organ transplant recipient, and they gave a mechanism how to find out the presence of these antibodies with the help of complement-mediated cytotoxicity test, which we all of us still use in our labs. But over a period of time, many tests have come into the in our lab, including Luminex tests, next generation sequencing, and so on, and becoming HLA lab more and more complex nowadays. These are some of the tests which are commonly done for pre-transplant and post-transplant tests. Some of the tests are called cross-matches, CDC cross-match, flow cross-match, and Luminex-based lysate cross-match. We do antibody evaluation on the basis of PRA and analysis, as well as single antigen test. We do HLA typing. It could be low resolution, it could be high resolution HLA typing using NGS mechanism. First, about the cross-match, whenever you do a cross-match, we need a patient sample which will have antibody. We need a good quality donor specimen which will have a donor cells. Sometimes this is important in case of cadaveric transplant. We do not get good quality cells, and the whole cross-match is not up to the level which we want. What do? We have a patient, the serum which will have antibodies, donor cell, we mix together and see complement-mediated lysis in the under microscope. If there is a good lysis, like 60-40% lysis, then we say cross match is positive. If lysis is less than 20%, we say cross match is negative and transplant can be done. Though the CDC cross match, which was started doing long ago, still we do, but there are a lot of limitations with this cross match technique. It could be false negative. It will not be able to detect low titer antibodies, even this patient is having antibodies. Second problem is the labor, and this is total manual test. So a lot of labor intensive test. It is doing many tests together. It's a challenge, especially in case of cadaveric transplant program. So therefore, the many labs are having CDC cross-match along with the newer technology of cross-match, which is flow cross-match or Luminex-based cross-match. Flow cross-match is flow cytometric cross-match, where we separate T and B cell and find out whether T cell and B cell are reacting with the donor patient specimen or not. On the basis of negative control, we decide. If both are negative, we say cross-match is negative. If both are positive, likely class 1 antibodies. If only B cell is positive, means class 2 antibody is likely present. Luminex-based cross-match is also popular nowadays. It's a solid phase assay with the help of donor lysate. We prepare lysate and react with the patient specimen, and we see whether cross-match is positive or negative. This is a very sensitive test. This could be false negative also, false positive also, since it's a very sensitive assay to perform. We also do panel reactive antibody test in our lab, which is it is an index of sensitization. On the basis of this test, we say, okay, patient is high risk, low risk, of intermediate risk as far as immunization is concerned. So we have a set of beads given by the manufacturer, and we run the beads on the panel. We find out what's the percent score the patient is getting. If it is less than 20%, we say patient is less sensitized or no sensitization. If it is more than 80%, yes, we say patient is highly sensitized. Last test, which is almost, we say is the most important test, which is called single antigen bead assay. In this assay, we find out which antibody patient has developed, and with the score of MFI, which is called median fluorescence index. So we run our patient sample on the beads, a panel given by the manufacturer. On one side, we have HLA antigens, which are the alleles present, and another side is the MFI value, which any antibody can have. So with the help of this information, we say, okay, which antibody patient has produced and what's the MFI value. So this is how we do single antigen test. On the basis of single antigen test, we identify which are the unacceptable antigens for this patient when this patient go for transplant. We also do virtual cross-match on the basis of this information, and this information helps in better donor selection, whether it's a paired kidney transplant or a disease donor transplant. So how we do the virtual cross-match? We do the patient single antigen test. Whenever donor is available, we do donor HLA typing, and we analyze which antibody is donor specific. So for virtual cross-match, we need the patient single antigen test and high resolution HLA typing. For Karnataka's disease donor transplant program, for all the patients go for CDC cross-match when a donor is available. The patient who have a history of sensitization, who has first transplant earlier, or multiparous female patient, we advise to undergo single antigen test, so that whenever we have a donor available, we do low resolution HLA typing and virtual cross-match for those patients. And for all those individuals, the donors, we do high resolution HLA typing later, and this HLA typing information is available in case of any post-transplant monitoring is required. Just a brief about one case. This female patient had some pregnancies earlier, some blood transfusion earlier. She had one transplant, and this transplant was rejected in 2016. Again, came to for the waiting for cadaveric transplant program. Many cross matches were done for this patient. Almost all the cross matches were positive. Almost nearly no hope for this patient. We did single antigen test and find out many antibodies in this patient. So start trying virtual cross match for this patient. Donor 1 again in cross match is positive on the basis of virtual cross match because anti-A11 was present. Donor 2 was also not suitable, but donor 3, though there was donor specific antibody was present but low MFI value. So this donor was suggested for this patient, and the patient underwent kidney transplant, and it was a successful transplant. So as we understand, there are several tests available. None of the test is actually perfect. For one test is not perfect. So we have to have an algorithm of the testing when we go for any transplant. So we need to select a cross match or the antibody test, which is PRA or single antigen test, and evaluate the patient when the patient should go for transplant. So we need to select a suitable cross match technique, whether our transplant program is living donor transplant program or cadaveric transplant program. Of course, the patient are sensitized or not sensitized. So for sensitized patient who have very difficult phase in getting correct donation, for those the patient we have to evaluate with the help of single antigen test which antibody they have developed and virtual cross match whenever is required. Nowadays also we need to consider about non-HLA antibody test when the patient is having ABMR and we find out there is no HLA antibody. So non-HLA antibodies can also cause antibody-mediated rejection. So with this, thank you so much.
Thank you so much for your talk, sir. Any questions from the audience?
Yeah, we have the kit available now. From last 6 months, we do a couple of tests we have done for non-HLA also. Sorry? It's like in one day, it's like single antigen test, yes.
Also the PRA, which you mentioned, the kits, are they from, do they represent the local population or?
No, that's the problem. We do not advise PRA tests to be done. Whatever the kit we have, all are from America. So this is again a population based. So there's no point of having a PRA score, giving 60% or 80% for the kit which is manufactured in America. It's not relevant for our population at all.
So, I mean, is there a kit with the local population being prepared or not really?
As of now, there is no scene this something is going to prepare. But another aspect looking at this PRA score, since it is not, say, our PRA scores in US is valid or is more relevant because their transplant program is cadaveric transplant program. And second is whenever we talk about PRA, we generally forget in US it is CPRA, though the C is small. CPRA is calculated PRA. This calculated PRA means you do a single antigen test and run the antibody, the information on the HLA tapping of your population. Since we do not have our population's HLA tapping available, we cannot do CPRA calculation in our population. So both this PRA score doesn't really matter or become relevant for our transplant program. Second is our transplant program is still 80-90% is living donation. So any patient will have hardly 1 or 2 donors available from the family. So having PRA 60% or 80% doesn't matter. Either you have to go for transplant, do antibody removal and go for transplant, or do not go for transplant.
Thank you.
Thanks for such a lovely presentation. The question is, so what are the options when we have a distant donor, like someone's in Davangere and Belgaum for cross match? Is it CDC or can we do virtual cross match?
We can, you're talking about donations happening or the patient is?
Recipient in Bangalore, donor is in Belgaum.
So, okay, for North Karnataka, we have a lab available in Hubli, in KIMS. So all the patient who are undergoing transplant in that area, we have a lab in KIMS Hubli. So CDC cross-match is done in Hubli. Virtual cross-match can be done anywhere. But the patient who are in that area, if single antigen test is there, we can get the sample from North Karnataka and do HLA tapping in 6 hours.
So turnaround time for between these two tests?
For CDC cross-match and HLA tapping, we do parallel. So between 6 to 8 hours, everything is over. Yes.
Thanks. And this non-HLA kit, which are the common things which we are
See, in non-HLA, there are...
Or what you have found it so far?
This non-HLA is very tricky to say. First of all, most of the non-HLA antibodies are auto-antibodies. So we do not know whether the patient was having antibody before transplant or this patient has developed antibody now. And some of the antigens are very difficult to capture for the beads, especially endothelial antibodies. So the endothelial antibody is still not covered by the bead manufactured in whatever the manner. So this non-HLA antibody is still is a theoretical approach of it is advised for the patient who has ABMR, the query ABMR, but when you do single antigen test, you do not find any antibody. You do not find any donor-specific antibody. So for those cases, if we want to find out the answer, okay, what's the answer for this ABMR when there is no HL antibody? So for those patients, a non-HL antibody is a relevant test to be done.
Yeah. Thanks for answering. I want to know which is reflecting currently in our Indian database. Did you find Vimentin or something like that? Non-HLA, there are some different, well-defined for heart, lung. So did you find any particular which is described in Western world, or this is something new you are able to find?
No, we are we all of us, first of all, very few tests has been done for Indian patients wherever in north to south, whatever we have done, and we use the kits manufactured in America. So all of the whatever experience I have in our lab, we have almost 10 samples we have done. Out of 10, 8 patients have antibodies, and all the antibodies are many antibodies. So I'm still surprised all these antibodies were developed before transplant. Also, this patient had these antibodies, or now they have developed these antibodies. So the panel has 6 antigens, and whenever you see, you will not get 1 or 2. You will get many antibodies in this patient.
Thank you.
Thank you so much, sir. And I'd like to thank everyone in the audience for staying this late. And last but certainly not the least, we have Dr. Rajni ma'am, State Joint Director Medical and Member Secretary of SOTO Karnataka. Here we have the honor of your attendance, ma'am, and thank you so much for enthusiastically participating and engaging in all the discussions right from the start. Thank you, ma'am. And we'd like you to just give some concluding remarks on the SOTO activity in Karnataka and future directions.
At the outset, I thank Narayana Health for inviting me for this session. And this is a holiday for me, essentially government holiday today's. But still I made my mind to attend this session and stay till the end of the session because it has helped me so much. It has given me so much insight to how to take the program in next future. And also I have come across with so many people who have come from government background like Mr. Bhagirath. And also as a DHO, so many transplant centers I had issued the KPME license in way back in 13 to 17. Now it's my pleasure to register them as transplant center as SOTO member secretary. And also I have seen SOTO has grown like anything from Forte, ZCCK to SOTO. And Karnataka, to my pleasure to announce this, we stood second in all over India in 23-24 with 178 transplants. Disease donation. And before last year, we stood fourth by 151 donations in the 21-22. And also, our Honorable CM has announced the honor of giving a certificate by the district administration within the first 10 days of disease donation by the district administration to the deceased donor. But when I took the SOTO position tenure 7 months back, whatever the BMSG, HLA, these words all sounded foreign to me. But now they are also very familiar to me with Mr. Ankit. Recently we discussed about paired kidney transplant in Karnataka. We are already rolling out paired kidney donation. 2 meetings have occurred. So I am very happy. When those words were very foreign to me, now they are so familiar. I am rolling out the program even for the paired kidney donation in Karnataka. So this transplants as, and I don't have to more give the details of Jiva Sartakate because Akhila gave all our statistics. We stand third in all India by organ pledging. And when we started this organ pledging as a part of Ayushman Bhava Mela, nobody imagined Ballari can stand so high with more than 4,000 organ pledging. Maybe there are so many dialysis patients in Pavagada belt and northern Karnataka belt where so much hard water or fluorosis, I am not aware, but so much awareness towards the organ donation is there where people are having more dialysis patients. And we do have national program like Pradhana Mantri Dialysis Program as well in Karnataka with a PPP model is running. So I have made all leaping steps in SOTO, like we are registering all people who are having dialysis with medical fitness for Jiva Sartakate. And I am also happy when the Jiva Sartakate name was coined. Mr. U.T. Kadar, now the Honorable Speaker, who coined this word. I was DHO Bangalore Urban at that time. When that word came into existence, I was there in the part of that meeting. So that word Jiva Sartakate gives me goosebumps when that word is called by Jiva Sartakate, and nothing but it is SOTO of Karnataka. And I also feel very happy we stand second highest in the southern part of Karnataka. But at the same time, I am not happy when I compare myself with the other parts of the states of South India, where I have made some observations like the number of NTHRs are high in my neighboring states, and the government contribution towards the transplant centers are high in my neighboring states. And I have observed that facts, and we are into registering NTHRC in many number, and we have made orders to make all medical colleges NTHRC, and we are making all brain death committees and NTHRs. We are registering in no moment. And I am into making the process of registering transplant center online, just like KPMA. It will be your, to the pleasure of all transplant centers. Within 1 year, it will be online registration of transplant centers and NTHRs and brain death committee. And also, we are looking into the features of online organ allocation under the guidelines of NOTO. But we are all very much sure that Northern India is not much supportive to the organ transplant, so we are skeptical in accepting all NOTO guidelines. But yet I am revisiting the NOTO guidelines, whether I accept, so that our organs do not go to the much of ROTO. But again, in the heart transplant, I observed about 179 organ donations, heart transplant has occurred. 33 have gone to the ROTO. 33. So means our heart transplant centers should increase in number in Karnataka. And everybody knows the most awaited organ is kidney. The second most awaited organ is liver. And even the transplant centers numbers are like that only. More are kidney, next is liver. Our heart and lung transplant center should do more. And as I am visiting in the hospital-based authorization committee, I am the member. I am recently seeing more foreign citizens are also get transplanted in Bangalore. No way, our phenomenal Devi Shetty and Narayana Health, which has contributed to the tourism of medical tourism in Bangalore. But we are also observing those facts as well as by the policy matter in SOTO. We are observing as my first question to the first speaker, to the survival rate, the quality of the organs and the tissue fluid, whatever it is transmitted during the harvest. And we are also looking into the airlifting of the organs. We are making it a policy matter so that we can pay and donor maintenance fee, transplant processing fee. These things are all discussed by our head, our IR officers, and we are going to improve these decision-making things and the advisory committees. To be frank with you, Karnataka is one of the transparent state all over India in transplant. Whatever the transplants are occurring. I have recently come across FIRs in neighboring states. That also few of our Mangalore citizens are lured by the neighboring state for these organs. That also I have taken into cognizance as appropriate authority. I have recently got 2 or 3 complaints against few hospitals for not following the norms. That also I am looking into, because appropriate authority is quasi-judiciary in nature. I have taken into cognizance of those complaints also. But to boast, Karnataka is way forward ahead compared to Northern India, and very few competitors are with us by neighboring states. And in next future, with support of all transplant centers, we are going to be #1 in South India. And I am very much sure, and I want to boast, and I want to thank all of you that Karnataka is one of the most advanced state and also in transparency in organ transplant. So I thank from bottom of my heart for inviting me to this session. And in fact, it gave me more insight when I used to work my transplant coordinators, where nowhere in India, transplant coordinators will be on site during deceased organ donation. Only Karnataka sends 3 transplants coordinators to the on-site organ donation, and all other states work on phone. But still they are so much ahead, and I want to beat that norm, and I will become #1 in next year with all your support. So Jai Hind, Jai Karnataka, and Jai SOTO. And madam gave me this last session because she knows SOTO comes only when the brain death occurs. So she might have asked me to give this session at the end, but I am very happy. And one of the lung transplant surgeon was telling they can tell stories. If the breath is, when I was a PhD medical officer, I used to call the asthma patient in first, because I used to tell other patients who are waiting, that's the only fellow who pays for his breath also. All others pay for water, land, tax, but the asthmatic fellow pays for even, or the breathless fellow pays even for his single breath. So that was my vision in PhD. And SOTO is my only 10% of job. As joint director of medical, I have got other works, but still I am fascinated by SOTO. And I was more fascinated by SOTO when I took the second award in Tamil Nadu, Chennai, when I saw a beautiful girl with her father. I have got a photo in my mobile. She was transplanted twice for her heart. Twice. And I am bothered about my pricks. I hardly take any, even TT was taken by me only when I was antenatal in pregnancy. So I was astonished by the fact that that so beautiful girl in her 30s, she has already undergone second heart transplant. And the proud father was looking at her. That has changed my vision towards transplant. So I wish the same vision occurs in the deceased organ donation. And by the survey it is made out, people are way forward thinking than us. People are more towards organ donation. We people are not facilitating enough to get the organs. So we should, as Akila made it out very frankly, we should facilitate organ pledging and organ donation, because I have seen whether it is live donation or it is deceased organ donation, people are willing to donate. We have to just support them. And that support should come from all the doctor fraternity, the paramedical fraternity, and the administration, SOTO, and the policy itself. So thank you for me giving this opportunity. Thank you, one and all.
And thank you so much for your active participation and making this event a success.